Ladies and gentlemen, please be seated. We are going to proceed the meeting soon. Assalamualaikum warahmatullahi wabarakatuh.
Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan.
Selamat siang, salam sejahtera kepada kita semua.
Good afternoon and a very warm greetings to each and every one of you. Kepada yang terhormat Direktur Jenderal P2P, Direktur P2PM, Ketua Tim Kerja TBC dan ISPA, para pejabat struktural dan fungsional dari Kemenko PMK, Kemendagri, Kemenkumham, dan BPJS Kesehatan, para pejabat struktural dan fungsional di lingkungan Kementerian Kesehatan, partner dan mitra pengendalian TBC internasional maupun nasional, CCM, TWG, Komli TB, Jetset TB, Kopi TB, STPI, PR Konsorsium Penabulu STPI, Stop TB Partnership, POP TB, YKI, Adinkes, UNAIDS, UNDP, UNICEF, USAID Indonesia, USAID TB Star, USAID TBPS, TB Caucus, WHO, dan organisasi-organisasi pasien TBC. Peserta dari Dinas Kesehatan Provinsi dan Kabupaten Kota terpilih.
We also want to welcome all distinguished external consultants from WHO, Bill and Melinda Gates Foundations, USAID, Stop TB Partnership, FHI 360, KNCV Tuberculosis Foundation, and Global Fund, also all respected TB partners, speakers, moderators, and all participants who attend today's meeting.
Distinguished guests, ladies and gentlemen, welcome to the Grand Melia Hotel, Jakarta, for the debriefing meeting of the Joint External Monitoring Mission, or JEMM, of the National Tuberculosis Program 2022. Ladies and gentlemen, please let us introduce ourselves. My name is Jonathan, and next to me is my dear friend Siva, and we will be the master of ceremony for this meeting today. On behalf of the committee, we extend our appreciation for your presence today. On this special day, TB stakeholders, partners, and experts are gathering with us here from around the globe, all with high spirits, excitement, and enthusiasm.
Today, with the same goal and purpose to have the world free of tuberculosis that make us stand together side by side to conduct this joint external monitoring missions meeting. And I would like to give announcement for those who need translator device. We would like to inform you that we provide the translator device in the front desk. Mohon Bapak Ibu bagi yang memerlukan device translator bisa mengakses device tersebut di depan. Baik Bapak Ibu, let me read our today's agenda. So today's agenda will be opening remarks. We have opening remarks by our directors, Dr. Imran, and will be following to the presentation on key recommendations by the team leader of the Joint External Monitoring Missions. And then we will have discussions, and then there will be a response and action plan from the Indonesia Ministry of Health, and then we are going to closing the session of today. So we are hoping to finish the sessions by 5 p.m. today.
Distinguished guests, ladies and gentlemen, to start our meeting today, we would like to invite to the podium the Honorable Director of Communicable Disease Prevention and Control of the Ministry of Health Indonesia, Dr. Imran Pambudi, MPHM, to deliver his opening remarks for the debriefing meeting of the TB Joint External Monitoring Mission 2022. For Dr. Imran Pambudi, the time and place are yours. Thank you.
Yeah, thank you, Jonathan, Siva. All distinguished guests, ladies and gentlemen, good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Distinguished guests from Ministry of Cabinet Secretariat, from the Coordinating Ministry from Human Development Culture, Ministry of Finance, Ministry of Education, Culture, Research and Technology, Ministry of Social Affairs, Ministry of Villages, Development of Disadvantaged Region and Transmigration, the Ministry of Law and Human Rights, the Ministry of Home Affairs, the Ministry of Labor and Employment, and the Ministry of National Development Planning. And also all of the TB partners and external consultant from WHO, Bill and Melinda Gates Foundation, USAID, Stop the Partnerships, FHI 360, KNCV and Global Fund, led by Professor Cakaya. So first of all, I want to convey regard from Dr. Maxi, the DG, that he couldn't come, join to this important meeting since he is now on the way from Wakatobi to Jakarta. So ladies and gentlemen, the TB problem is a massive challenge for us and the worldwide community. Currently, Indonesia is the second largest contributor to TB cases in the world after India. It is estimated that every year there are 969,000 new cases of TB with 144,000 deaths from TB in Indonesia. And we still have to work harder to our achievement until November 2022 are far below the target, with the treatment coverage still around 63%. As one of our efforts in implementing TB program review to achieve TB elimination in 2030, the Joint External Monitoring Mission for the 2022 National TB Program will be held. And JEMM of the National TB Program is conducted every 3 years with the aim to review the progress of the National TB Program achievement from 2020 to 2022, and will provide an evaluation as a basis for making evidence-based decisions about interventions, strategies in order to achieve TB elimination. Maybe this is just repeating because I know that several guests here is not in this same meeting from 3 days ago. So I want to repeat this one, the information. And also the last JEMM was held in January 2020 with the aim of monitoring the performance of TB control program in Indonesia from 2017 until 2020. And in 2020, the review was carried out by visiting 4 provinces, which were South Sumatra, West Java, East Kalimantan, and East Nusa Tenggara. And this year, the National TB Program, along with WHO, carry out a series of JEMM activities on 5th until 14th December 2020. And the review carried out by visiting 4 provinces, which were North Sumatra, Yogyakarta, North Sulawesi, and West Kalimantan. And yesterday, we already briefed with the Minister of Health, and I think several points and recommendations already discussed with the Minister. And today, at the debriefing meeting, the result of JEMM 2022 activities will be presented based on the reviewers that have been carried out by all reviewers to subsequent become recommendation for National Tuberculosis Program. And the main challenges that have been identified and will be presented by reviewers from JEMM activities in the last 2 weeks are: first, active case finding activities; second, the limited actions at the most peripheral levels; the third, existing JKN payment mechanism; the fourth, the proportion of the missing people with TB is a result from the lack of utilization of existing data system; and the last, inadequate capacity to plan, budget, analyze, and interpret data at the local level. Furthermore, in the debriefing meeting, the recommendations from the reviewer team will be presented based on the 16 thematic areas that has been explored and become the main focus of JEMM implementation in 2022. Some of the thematic areas are active case finding, TB-HIV, childhood TB, and also social protection. Ladies and gentlemen, I would like to take this opportunity to thank all parties who have supported JEMM 2022 activities, especially today at the JEMM debriefing meeting for the 2022 National Tuberculosis Program. And it is hoped that from today's activities, information can be conclude about the whole JEMM 2022 activities, as well as the recommendations obtained to all participants and partners who will be involved. That's all of the messages from me this afternoon, and I'm sure that all participants will participate actively and enthusiastically in the JEMM debriefing meeting, so we can get the best result possible. Finally, by asking the protection of God Almighty, I hereby declare the 2022 debriefing meeting of Joint External Monitoring Mission activities officially open. Thank you. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Imran, for a very warm and encouraging remarks. So, ladies and gentlemen, now we're going to move on to the main agenda, which is the presentation of the key recommendation from our team leaders, JEMM 2022. Dr. Jeremiah Chakaya, please, the time and place is yours.
Assalamualaikum. Thank you to the MCs for the opportunity and for the introduction. I think we will go right into it because we've got a lot of things to cover and a lot of. We hope we'll have a great dialogue even in the space of limited time that we have. Can I have the next slide, please? Before we go to the crux of the matter, I think it's appropriate that we acknowledge those who made it possible for us to be here today and to do this work. Some of us are very strong believers in God, and therefore I personally would like to thank God for the opportunity to be healthy, mentally and physical, to have been able to participate in this very important exercise for TB care and prevention in Indonesia. We may not have listed everyone who needs to be listed, and if we have missed you out, we would want to say a big sorry for doing that. But we want to thank all the people that are listed, all the organizations that are listed in this slide, again, for facilitating this very important exercise in Indonesia. Let's have the next slide, please. Just to remind you why we came to do this, what was the overall objective of this JMM. Like most other JMMs, the idea was to try and find out how the national TB response has progressed since the last JMM that was done in 2020. And in essence, that means how have we progressed with our national strategic plan that came out of the JMM of 2020. Next slide, please. And we had a long list of things that we were meant to review. And today you will hear how this country has progressed in many of these areas that are listed there. Those were our main thematic areas for this JMM. Next slide, please. So how did we do this? As usual, we went into documents, we looked at the National Strategic Plan, we looked at the funding request to the Global Fund, and we looked at published literature and so many documents. We visited the field. We interviewed people, had dialogue with people, and then in the last 2 days, we've been synthesizing the information that we picked up in the field and in our reading and what have you, and have now synthesized that into a set of recommendations that you will be hearing today. Next slide, please. Unfortunately, I wasn't able to show you, in colors the places we went, but just to tell you that we visited 4 provinces. We were in West Kalimantan, we were in Jakarta. I hope I'm pronouncing that appropriately. We were in North Sulawesi, and we were in, which is the 4th one? Yes, North Sumatra. So we went to 4 provinces. Now, this is really important for you to know that this was not an audit of the national program. If it was an audit, we would probably have gone everywhere to be able to look at things that way. The idea was to get a snapshot of how things are happening in this country and how those are impacting the TB response overall. Next slide, please. We did mention these things to the Honorable Minister yesterday. As you've been told, we had the opportunity to debrief him on what is happening to the TB problem in this country and how this country can move forward with his help as the captain of the ship that is called the TB ship. And there are several issues that I think many of you in this room know. We have a very strong, or you have a very strong TB care and prevention program that reaches every part of this country. You have been trying very hard to implement all areas of the NTB strategy. You've got a very strong political commitment, as evidenced by the fact that you have a presidential decree and you have a health minister now who is very keen on the TB problem. You are emerging as a country, as a global leader in contributing to TB. You have already started engaging various ministries and also people who are outside the Ministry of Health. And before the COVID era, the amount of financing that was coming through for TB was increasing, and that was consequently reducing the incidence notification gap. Some of these things were disrupted by COVID-19, as happened in many other parts of the world, but before then, things were going in the right direction to some extent, and we hope that we can go back to beyond the pre-COVID era. And your case notification is gone up again this year and is expected to be over 600,000 people will be identified or have been identified and put on treatment this year. Next slide, please. But the problem and the mountain that needs to be climbed is a very high one. If you just look at the number of people who are developing TB and the commitment that we made to be able to get to the 2030 target, that mountain is really, really tall. If you look at the number of people that are dying from TB in this country, again, to reduce those numbers to what they should be by 2030, that is another huge mountain that needs to be climbed. Next slide, please. The Stop TB Partnership has modeled your epidemic and have looked at the effects of several interventions that could be applied in this country and what those interventions might be able to do. And if you have a combination of all these things being done, the Stop TB Partnership at the global level, as they prepare their global plan for ending TB, are suggesting that in fact it is possible to get to the targets of 2030 if you are to do all those things, PPM, diagnostics, case finding, and detecting subclinical TB. Now this is really important. Unfortunately, in our discussions here in the last 2 days, we did not touch on detecting preclinical TB, but I hope we're still going to have a little opportunity to speak about that as we go forward. Next slide, please. So those are some of the key gaps that we mentioned to the Honorable Minister yesterday, and they have already been highlighted by Dr. Imran today. And I think it's still critical for us to know that these are the major things that this country needs to address. We are not finding enough people with TB because our case finding activities are primarily passive. We are not screening people in huge numbers, and we have not trained our case finding activities with TB preventive therapy. At the post-Christmas level and even in the lower healthcare system, there seems to be very limited action happening at that level. Then we have the financing issues, and then the data issues, and the fact that the capacity to be able to plan and lead the program at the subnational level seems to be weak. Now, all these things will be highlighted in much broader terms today, or in much more specific terms than we were able to do yesterday when we were briefing the minister. Next slide, please. We had mentioned these are some of the key things that needs to be highlighted, but each and every one of these has got many sub items that need to be looked into. So addressing the payment system, mobilizing communities, strengthening TB screening, and strengthening TB management capacity. And all these things, you will hear a lot more about them in our presentations today. Next slide. So having gotten to that point, I will now be asking people who are leading the thematic areas to come up and to come and give you summaries of our key findings, the key gaps in each of those thematic areas, and the key recommendations. And I'm going to start with finding people with TB, and this will be presented by Ken Castro. We have the right one.
Yeah. In fact, if I may have the slide, I hope we have the updated version. Nope. Nope. No, this is not the updated version that I sent through the WhatsApp chat before lunch. I would suggest that if you want to skip over to the next session until we update the slide. Thank you.
All right.
Any questions?
Okay, so let's go to the next one. Unfortunately, they were all coming in such a huge, whatever, it may be difficult. Let's go to next. Keep going until we get to the next. Okay. I hope this. No. You've gone too far. Go back. Addressing TB comorbidities and vulnerable populations. Please stop there. Yes, there. Stop there. I hope we have the right presentations, and this one will be done by Srinivas.
Thank you. Good afternoon. This is in the order when you are actually talking about the active TB case finding. Maybe it is not just accidental. This is probably the right, because the active TB case finding and to reaching the people early with the extra effort is absolutely required for the key and vulnerable population. And we will be really talking about the importance of that one in our group first. First slide, please. So the key and vulnerable population for tuberculosis, we keep them, one is, these are the people who have an epidemiologically higher risk of developing tuberculosis, like those groups of people who might be much more exposed to tuberculosis bacilli, as well as those, if they have infected with the tuberculosis bacilli, there are a group of the people who would be breaking down much faster than the normal people. But there is equally another important one, is that those who have, due to their social status, their living standards, what sort of groups they belong to, for reasons which are not their faults at all, they don't have the real access to the health service. So that socially as well as clinically risk groups are, we group them as key and vulnerable population in tuberculosis. And addressing those people are important for finding those missing millions. Say, for example, if you are going to find 90% of your TB burden in the country, we always talking about the low-hanging fruits and the people it is easy to find. The key vulnerable population would be the most difficult to find. So even if we find 90%, if that 10% missing people, there is the very likely chance that it will be the key and vulnerable population. So it is extremely important that special efforts and actions need to be done to address the key and vulnerable population for not only finding missing people, but also very importantly on the equity and the human rights point of view. The National Strategic Plan of this country 2024 clearly identified some of those priority population and also what actions need to be done among them. This is also when we talk about the people with key population and the comorbidity, we need to consider about the need to address them separately, more intensely to prevent TB death. So it's not just, there are two targets we look at. One is about reducing the incidence, but it's also about reducing the mortality, and addressing comorbidity in people with the tuberculosis is an extremely important area to address. Next slide, please. So the key findings in our joint monitoring mission, we have, in earlier days, we were not really talking about one comorbidity, that is COVID and TB, but now we cannot ignore that. We have gone through a difficult path in the last 2 years where this particular pandemic has created havoc in all spheres of life, but very importantly for the people with tuberculosis. And the programs have also been suffered. So, so what we have observed is that for the COVID and TB, the TB program has developed some guidelines. There has been some innovations in the care delivery, like monthly dispensing of drugs, digital monitoring, teleconsultations, hotlines, etc. These are really good. There is also, yeah. So as far as the other comorbidity is concerned, it is it's diabetes. We know that Indonesia has got a very high prevalence of diabetes, and there is national policy for screening of diabetes among tuberculosis exist. The observations, our teams, some of the team have seen some districts excellent performance of testing diabetes among all tuberculosis patients and also linking them with the right care. However, this was not observed in other teams. Or in other words, it means that this TB diabetes collaborations and better care for the people with the tuberculosis is possible. That has been demonstrated in some places, but the observation is that it is not at scale in the other places. So this is, I will look at it as an opportunity. There has been active case finding in prisons. We know that in prisons it is one of the high risk group for TB, both for infection as well as diseases. And we have seen some excellent active case finding interventions in some prisons, while in other prisons we have seen active case finding, but it is not that regular. So there is a spectrum. On one side, there is active case screening with the chest X-ray or rapid molecular diagnostics were utilized. Even TB preventive treatment were given to the prison because they are all in the policy. We cannot say that it is not policy. The policy, it is there. And in Indonesia, it is implemented in some places, but it is not implemented at scale in other places. Household contact investigation is another active case finding activity. We know that households have got a higher risk of both infection and disease. There are policies. There is practice also. The challenge which we observed is that the monitoring of that one is not very, so we don't know how good, bad or ugly the performance is because of some challenges in the monitoring, especially the monitoring the data from the community system, integrating that into the SITB is a problem. The other one is that in all these active case finding efforts, it is more on symptom screening. We know that symptom screening generally is not a very sensitive one. We are continuously going to miss people. As Dr. Chakaya in the introduction, he mentioned about the subclinical tuberculosis. We are definitely not going to get any subclinical tuberculosis if we are only starting with the symptom screening. Community level sensitization programs were observed in different places. That is good. But probably we need a much more widespread engagement, and this again the strategy of communications need to be much strengthened. We haven't an important comorbidity for tuberculosis, both as a causative factor for tuberculosis as well as it takes a very important role in the cure and also the long-term health of the person is undernutrition. This we haven't seen any conscious effort in addressing the nutrition in tuberculosis patients. There has been no nutritional assessment or deliberate attempt to ensure that there is adequate nutrition to the people with the tuberculosis. We haven't seen, obviously, any active collaboration with the other programs like non-communicable diseases. In comorbidity, whether it is diabetes or tobacco cessation or mental health, these are all being put under the non-communicable disease program, and now it's extremely important to have strong collaborations and coordination with that program. And also the opportunity to link with reproductive, maternal, neonatal, child and adolescent health programs. This because there is a lot of resources, the healthcare workers, and these are the people are always within that program. You know, the children and the mothers are always with that program, and the linkage with tuberculosis, and if they start thinking about tuberculosis and addressing tuberculosis, this is another big opportunity we need to explore, which we didn't see in the review. Next slide, please. So the recommendation is, first of all, for the COVID and TB, we have some opportunities and I should say lost opportunities, but there is still opportunities to really look at it, and both COVID and tuberculosis are airborne transmission, both are respiratory, both are similar symptoms, and probably the next pandemic is also going to be airborne, so we, the people working in tuberculosis, has a responsibility to talk about tuberculosis as also an important component of any discussions on pandemic preparedness. So, and the resources can be also be mobilized for TB, or in fact, TB platforms can be very well utilized as pandemic preparedness. So, exploring that is important. we also need to look at further explore the funding opportunities available either with C19 RM or even other reprogramming to utilize some of those resources further for TB screening and diagnosis. We recommend there is a TB NCD collaboration established at the national level, but that need to be further invigorated and expanded into the provincial and the districts level to address all this, the comorbidity challenges. So, like establishing the provincial and district collaboration, TB and the RMNCH programs, the IMCI programs, etc. We also, there is a TB key vulnerable population we cannot ignore, the elderly population, both because of that higher prevalence of tuberculosis and also because of the access challenges to the health services. So the geriatric clinics, diabetics clinics, all of them need to actively search for tuberculosis, and for that one we need to create systems. We need to train people, and there need to be facilities available for that one. We recommend that strongly. Implement the proper recording system for TB comorbidities, and it's important that what gets monitored gets done. So if you don't really monitor, we wouldn't even know that it's done or not. So the bidirectional screening and referral for TB diabetes, regular TB screening for TB in diabetic clinics, diabetes screening and referral for treatment of TB patients, etc. Next slide, please. So similarly for this nutritional assessment, we have also, this is also part of the, the social protection and the social support mechanisms. Probably there is more training or incorporation in the guidelines about in the TB training modules and all the training activities, the importance of nutrition and how to assess the nutrition, and nutritional assessment being an integrated part of the treatment. TB treatment is not just the drugs given to the patients. We need to again explore actively. This is also coming in the other department about linking that role with the Ministry of Social Welfare, systematically assessing the mental health and support activities in that, and exploring the smoking. Smoking is another major risk factor, and how do we link the smoking cessations in TB programs also. For the key and vulnerable population, we will strongly again recommend this active case finding, actively supporting people. There need to be not just diagnosing people, there need to be strong support to ensure that there is a social support for the people to complete the treatment. But it is important to identify who are the key vulnerable population, map them, prioritize them, not just at the national level, but also at the provincial and the district level, so that we can plan and incorporate that one in the national strategic plan, invest in it, and start implementing it. So these are some of those broader recommendations. Thank you very much.
Let's have the next set of slides. The next set of slides will be, I'm not sure whether we are able to show the active case finding slides. Not this one, not TB HIV, the one that has just been given to you. Then we can go back to this. Yep. Yes, okay, thank you. So, can you have it?
Thank you very much. I think that the having switched the slide worked out beautifully, because a lot of the background information about who should be actively screened is now quite self-evident by virtue of having heard Srinivasa's presentation. So just 3 slides, one with findings, the other one with challenges, and the third with recommendations. So Indonesia has started active case finding since 2020 in a series of pilot projects, which include detention centers, Islamic boarding schools, farming communities, fishing communities, coffee factory, and high-risk groups, which are going to be henceforth abbreviated as HRGs. And these are the contacts of TB patients, persons living with HIV, and people with diabetes. In the TB Control in Indonesia report of 2022, we see evidence of a higher yield of active case finding in high-risk groups as opposed to doing active case finding in the general population. So you can see that in 2020, there was 4.2% of TB cases among 3,696 high-risk group persons screened in 3 separate districts. In 2021, screening of a larger number of 41,000, almost 42,000 people in the general population based on symptom screen in 7 districts only yielded 0.3% of cases. In addition to that, we've observed during our visit to Jakarta that the Zero TB project has demonstrated how the increasing yield of active case finding by targeted contact and moving away from general populations. The Ministry of Health, we've learned, has established a memoranda of understanding with 6 big chain private hospitals, which encompass 255 facilities in 30 provinces to increase TB case finding. And there's an acknowledgement, and this comes from the report of the external assessment of district-based public-private mix, that there's a large proportion of TB cases, in fact 74.6%, first sought care from either an informal or a private provider. So it's going to be indispensable to engage the private providers in this country. The challenges, most of these active case finding activities rely on symptom-based screening. You've also heard from Dr. Srinivas that that's followed by molecular WHO recommended rapid tests, and some projects are including the use of chest radiographs. There has been, in spite of these activities, a relatively stagnant and low overall TB case notification between the years of 2019 and 2022. In many countries, we're seeing a recovery of post-COVID and a return to pre-COVID levels. So we haven't yet seen that. There seems to be a flattening in Indonesia. The active case finding yield is dependent on the population screen, so we keep harping on this. Higher in target high-risk groups with lower numbers needed to screen, and it is quite low when conducting general population screening with a much larger number of needed to screen to identify a case. And we keep underscoring this because you'll see that this is going to become a strong recommendation to move away from active case finding in general low-risk populations. Chest radiographs are not available either at Puskesmas or in prisons. We understand that this is reportedly limited by the National Nuclear Agency radiation exposure safety policies. And we brought this to the attention of Parliamentary yesterday. Resource shortages, such as limited cartridges, have limited active case finding in at least one of the districts visited. And TB infection diagnostics, whether you used tuberculous skin test or interferon gamma release assays, with TB preventive therapy have not been a routine component of active case finding. And again, the private sector engagement has been very slow in coming. The recommendations then that follow are to increase the access to portable chest radiographs combined with artificial intelligence as a basis for active case-finding screening, including updating National Nuclear Agency radiation safety policy, because these emit much lower radiation, and that safety policy is probably not up to date with the ultra-portable chest radiographs. define locally relevant high-risk groups. So we already know the context, people with diabetes, people living with HIV, but there are others that need to be locally defined on the basis of the epidemiologic drivers, and it would be presumptuous for anyone from the outside to tell you who these should be. You should use your own data to drive that information and inform those decisions. Assure an uninterrupted supply of health commodities when engaging in these activities. Make sure that TB infection diagnosis and TB preventive therapy are part of a package of care and prevention when conducting active case finding. Then implement the recommendations to optimize private sector engagement in active case finding. And these recommendations are provided in detail in that September report that I alluded to and cited here in the slide. And then another suggestion that we made, a recommendation is explore private pharmacy surveillance of anti-TB drug sales to identify underreported TB cases and priority private providers for potential engagement. And with that, that's our thematic area. Thank you for your attention.
Thank you. We're making good progress. Now we will hear about TB HIV collaboration and where we are. And this will be presented by Lisa.
Salamat Sori. Did I get that right? Thank you so much. I'm going to quickly go through the TB HIV thematic area. Once I figure out how to make this work. Here we go. Okay, so as you've heard, we went out to 4 different provinces in the country and had a look based on what we'd heard in our introduction, and then went to see how things were in real life. And we know with TB HIV that collaborative work started quite a while back in 2004 in Indonesia. And the number of people with TB who are getting HIV tested has slowly increased, with the most recent numbers being about 55%, although those vary. And when we test all the TB patients, we find that almost 4% actually have HIV. So it's really important not just for the TB epidemic to find people with TB and HIV and make sure they're being treated, but also for the HIV epidemic control. If you actually look at the prevalence rate among key populations where we invest a lot of efforts to find people with HIV, you'll see that the TB rate is actually a higher prevalence than female sex workers. So of the key populations, TB patients rank right up there. So it's really important, even from the HIV side. We know the next step after finding everyone who has TB and HIV is to get TB treatment started first, and then ART should follow very closely thereafter, so within 2 weeks. But that level what comes in the reports is quite low. So it increased up into about 40% a few years back before COVID, and is kind of hovering. The latest report was 34%. But that, I think, we found, and you'll see that there's a lot of reporting and recording errors, given that there's 2 different systems recording this information. So we know if people have HIV and TB, their TB treatment success rate is low, 58%, compared to about a 90% rate overall. So there are the last piece that we like to work on is TPT, which you'll be hearing a lot about this afternoon. But for PLHIV, the coverage has just been too low. There are some specific project areas that are doing a lot better, but in general, most of the sites we've seen, TPT for PLHIV wasn't easily available, and the national number is 11%. Okay, so our key findings, when you break it down by these different areas, with HIV, when we went to the field, we found variable levels of HIV testing rates, some as low as 30%, but then some of the sites we visited, it was 100% when you actually went through and looked through the cards and the registers. That may not be reflected in SITB, but there were definite barriers, including lack of HIV testing services, test kit stockouts, and stigmatizing approaches by providers who were trying to decide whether they should offer an HIV test. So not following provider-initiated testing and counseling where everybody gets a test. As Indonesia is very successfully testing all pregnant women for HIV, and it's not a problem, and we should have the same thing going on in the TB program. So I think we found there's a lot of area for improvement. And then this reporting disconnect between SITB, which is patient-based, and SIHA, which gives you aggregate reporting, and there's really no interoperability. So you had to, the one site we went to, they had to go back and do these MONEVs and kind of almost do a mopping up for TB HIV to get the numbers more accurate. So a really striking finding is that at the private facilities visited, they're not doing TB HIV interventions. There's probably some exceptions, but what we saw is nobody was getting an HIV test. So a big gap that may be really increasing what we're seeing in the numbers. And then at prisons, actually, everybody was getting tested for HIV on entry. So if you did screen and found TB, you actually knew their HIV status. So that was kind of a best practice. As far as ART, there's low levels of ART among TB patients, and a lot of that is recording. Again, the patient is sent to the HIV clinic, it's recorded in SIHA, and that message doesn't make it back to the TB clinic. But there were other barriers. Some were long distance travel. I'm told that ART is decentralized, but it's not decentralized far enough because there's a lot of places, a lot of puskesmas that don't have ART, and the patient has to travel to the hospital to get it. There's a delay, mostly coming from providers wanting to finish intensive phase, or some even wanted to treat the full TB treatment before starting ART, and we know that's not recommended. And then this poor communication between TB and HIV services to make sure that person actually makes it in and gets started. We noticed a predominant use of efavirenz still within the system for people with TB and for people with HIV that didn't have TB, when global recommendations are to move to dolutegravir-based regimens. Oops. And then for TB screening, everybody reports that all PL-HIV coming in to pick up their ART are being screened for TB, but we didn't see it well documented. And the screening tool that had been developed at some of the sites we visited, they weren't using it anymore. And even the providers weren't clear on what those 4 questions were. There was no use of lateral flow LAM. I think there's none in the country, or CRP testing, which are now recommended by WHO. So of the TPT, there was limited availability. Some sites we visited had stock, and they said, nope, those are for the contacts. And we know that people living with HIV and contacts of bacteriologically confirmed TB patients need TPT. So differentiating who it's for doesn't actually make sense. So the biggest barrier that we saw was there were actually no TPT drugs at the sites. Clinicians were also worried about side effects, about drug interactions, and there being too much work for the healthcare workers once you started a TPT program. In the sites we visited, only the ones I visited, only isoniazid was available, and we've heard that there's 3-HP where the impact for TB is working in 6 provinces, but otherwise the HIV program is relying on isoniazid. And there's a lack of community literacy. There isn't a push from the community for people to get going on TPT. So finally on the findings is just the collaboration. There is a national sub-working group that's active, but the next level down, sub-national, one of our teams found a TB-HIV4 core, but otherwise I think most places they're not functional as they used to be. And then down at the facility level, there's weak integration with this referral system between them not working, although there were some one-stop shops that were seen in puskesmas, which is definitely a best practice. So for recommendations from TB-HIV, here we go. For the TB programs, we really need to accelerate HIV testing. It should be kind of a no-brainer. Everybody with TB needs an HIV test, just like all pregnant women need an HIV test. There needs to be training. People need to know what PITC is and actually be implementing that approach. And we need to get to the private sector. If they're doing TB, they need to do TB HIV as well. We need to work on provider stigma towards PLHIV and other vulnerable populations as well if we want these programs to work. And then as much as possible working towards one-stop shop, as we saw in some settings. And then for the HIV program, the providers at HIV sites need to be clear on the guidelines, when ART start is recommended and why that is. And we need to further decentralize ART care. So if you can get TB diagnosis and treatment in a site, you can also get your HIV taken care of. Lateral flow LAM testing, especially on even CRP, are needed when you're dealing with patients with advanced HIV disease. And then TPT, again, needs to be prioritized for PLHIV. We should have all the regimens that are in the recommendations available and get providers and communities up to speed. And then recording and reporting is really important. I think I mentioned that below. So the last section is really to the people above just TB and HIV. So we're aiming at the Directorate of Communicable Diseases and people at that level in the PHOs and the DHOs who oversee both diseases. Because really, we have to work together to make this work. We need to strengthen that communication, networking, and coordination between the programs at all levels. Get these 4 cores at subnational level back up and working again. Push TB and HIV, as we're going to hear more about. There's the data transformation. Let's put TB HIV up there at the beginning because the current system with SITB and SIHA is not working. So if we can move into this ASIC Satu Sahat and get TB and HIV integration, that will be great. We need to work with professional organizations so they understand TB HIV guidelines. And there's a recommendation to look at what's happening with TB and HIV in pregnancy. You might hear more about that in the research. That's all. Thank you so much.
Thank you very much, Lisa. We now move on to TB diagnostics and the attempts that we have made in this country to achieve universal DST. And this will be presented by my good friend Puneet.
Thank you. So we've heard from my esteemed colleagues just recently to do a lot that we need to address comorbidities, and a big part of that is like, well, we need to. Those comorbidities are associated with TB, and so we should do more testing among those people to find more TB. And we heard about active case finding, which was like, well, there are these populations out there which we need to actively go get and do more testing and find more TB. And we heard about even TB HIV, where there's like one of the big parts of this is like, well, we actually need to do much more testing and find TB earlier among them. And there's more than that. But I guess all of this is getting to kind of one of the fundamental pathways forward here, which is we need to do a hell of a lot more testing. And how are we going to do this testing is one of the issues that we're grappling with here. And so, and just as one more point of context, if you are going to find 1 million cases, then you're going to end up doing at least 5 million plus tests to find those cases. And that's about well above and beyond where things are today. And so just keep in mind that that's a level of a common pathway for all of this activity to actually achieve the country's goals. So the existing network we reviewed, and just wanted to acknowledge the incredible strides that have been made towards both expansion of both capacity, tests being done, especially of molecular tests, improved utilization of said tests, although there's a big heterogeneity among that, and creation of a genuine diagnostic network. Next, please. And that's because of an enormous national commitment to improving TB diagnostics with largely national funding, for which the country should be commended for that commitment. And the policies are in place to use WHO-approved rapid molecular diagnostics for presumptive TB. There's improving services up to almost or more than 1,800 of the existing TCM platforms, plus including 500 which are capable of doing second-line testing for those patients who have rifampicin resistance. And there are more tests in the pipeline that's beginning to diversify the molecular platforms that are available for TB testing in the country. There's the potential for connectivity so that those results can hit the information system and be used to connect those patients to treatment and right away. A strong effort for supply managed by the program and improving service. There's been some difficulties with service and maintenance over time, but that's improving with at this time the reported 95% module uptake, which is better than it has been recently. That number would have been lower a year ago, I think. And improving coverage for second-line DST. And some of the numbers are shown there are kind of impressive. You know, when you can get 70% coverage among presumptive TB tested with a molecular test, that's among the leading progress in high-burden countries in the world today. So that's a worthy accomplishment. That's not where you want to get to in terms of finding all your missing cases, but it's great progress. Next, please. There are some challenges that were identified by the group, of course. That was part of the goal. The network is over-reliant on one technology and one sector. That is the public TCM usage, right? And there are some private sector TCMs that are noted that were unused for TB. And there's a massive post-COVID PCR network that's available with over, we heard yesterday, about 1,000 contractual PCR labs that were doing perhaps 250,000+ tests a week with transport and high throughput, but there's no sputum processing capability to connect those today. There's been module malfunctions that are getting better, but that was a challenge. Connectivity is a theory, but limited by both training and internet connectivity, as well as some software interaction problems, perhaps. And that's sort of system problems. And then there are some more central problems around the people who are doing the diagnostic testing, who need a lot more support. There's laboratories of HR rotating in and out, and that's a lot of training that needs to happen that doesn't happen as very often. The supervision of those peripheral laboratories is a system gap, where the constrained national level supervision to regional isn't extended to the next level of laboratory supervision from regional to peripheral laboratories. And accordingly, then things, even though the systems are fairly automated, things can go haywire. They require a certain level of ongoing supervision, expertise, and management to keep them running optimally. And there's challenges with EQA, and importantly, the laboratory system starts not only with the laboratory, but with the person collecting the specimen. That's a health worker. That health worker's got to do it right. Everything from collection to accessioning to transport, recording that specimen presumptive to transport, that's got to happen right. And that's so it's dependent, the system working is dependent on those health workforce being trained to interact and engage with the laboratory system successfully to get your result. Next, please. That's the sort of system stuff. But then there's how you use that system to find cases. The low utilization of that testing by engaged private providers was noted with some gaps around all aspects of that cascade of activities, from ordering to collection to transport and getting those results back. You have a vertical transport system that's run by the program, which is kind of amazing what you've been able to achieve with that system, but it's very heterogeneous with coverage for public more than private, and its variable mechanisms and performance. So it's called ad hoc, right? Local problem. And there's lower uptake of referral. You know, it's hub and spoke is an efficient way to do things, but at the end of the day, when the test is on the site, people get tested more. And that's not unique to Indonesia. That's a global observation. So there was more than 2.5 times more testing when there was on-site testing versus hub and spoke. So decentralizing in smaller hubs placed intelligently give you more tests. Alternate specimens can be used, but that's not really known or implemented, even for places which should be implementing it, like hospitals, whether it's stool or other extrapulmonary specimens. And we talked about training and turnaround times. And second line testing had some gaps. Next, please. We'll move on. That's a bit cut off, but the presidential decree has made diagnostic testing a public health function. And some of the consequences of that is that testing is a little bit disconnected from the health system operations as a whole. And I think that's one of the core themes of the mission. And so those clinical services are somehow owned and operated by the public health program. So what you've achieved is heroic, and you've gotten there fast, with rapid scale up. But now you are in a situation where you have to go much farther And so getting the health system to own more of those diagnostic services will help you go farther. And if the health system itself, the public health system, is really only serving, so let's say 2/3 of the people in any of their care, the diagnostic access means that all of the people need to have access to those tests, and unless they're available to patients and used for patients seeking care in private providers, it'll not be you'll be leaving a lot of cases on the table. Next, please. So the top level recommendation, so it's been incredible on the how the diagnosis is being made. Now there's a bit of a transition that needs to be made into the who gets tested. So in terms of the core recommendation had to do with strengthening access to those primary care patients. And whether it's going to be at the operational things that can be done, say for example, improved on-site testing in Pesmas with diversified tests and optimizing those hubs and spokes and improving those access to private providers, there are also some structural changes that would be made that could improve and incentivize testing from all levels. So this is an interaction with the part about the systems and the health financing work, which is, there are a number of models that have been discussed in depth throughout the mission. And what the exact perfect pathway forward is, I don't think anyone knows. But they should definitely be tried as quickly and efficient and as possible so that the pathway can be cleared out. Whether it's payments that are going to incentivize that kind of bacteriological testing at the primary care level, public or private, which is a different, whether it's performance-based capitation based on improvements in testing, or perhaps even making the ownership of those tests part of the health system, or that those aspects, structural aspects, are likely to be necessary, and just fixing the operational part about a better system isn't going to get you the kind of change in testing behavior that you need to find, many millions more people. In addition, the systematic screening effort, especially among those seeking care at primary care levels, is a great way to find a relatively high yield group of patients, and that could include risk factors that move beyond symptom screening into just testing those people with those high risk factors, understanding that the hit rate is still pretty good, and it'll be a good way to find cases without having to go too hard. That's, if you will, in your hands. Next, please. On the network, the basic point about a lot of detailed specific recommendations is to reorient this diagnostic capacity for those primary care systems, and that'll allow you, improving both their quality and performance. And that's including addressing this core supervision issue, and that requires a clear and costed plan for doing that supervision, EQA, and quality management systems. The network of tests itself, we discussed in the ministerial meeting yesterday also about the issue of diversifying those platforms away from the single technology into other technologies that are now available, and emphasizing placement at those primary care levels. At the same time, trying to see how the high throughput PCR available for COVID could be used. Think of what the country achieved for COVID PCR testing. No one can say that's not achievable for TB. To get that level of testing, rapidly stood up and integrated. There are some things to plug in to get there, but no one can say it's not doable. And there's the connectivity points. It's one thing to have the software, but it's another thing to actually have real connectivity. So that's something that could be fixed very fast. All the data should be automatically available, and that's a doable. Next, please. This is my last, I think, slide. Getting more tests done. You've heard a lot. This is not the only group that's to focus on this issue. How do you find more people to get them tested? Right, but whether it's going to be from engaged private providers by having these easier systems and incentives that are aligned with it, whether it's better transport systems for both public and private and remote locations, whether it's increasing testing of non-sputum specimens, all of those ways to get more utilization out of your system, get more people tested, I think are all going to, will have to be pursued in parallel. The second line DST could be probably improved very easily by taking advantage of your existing now second line capable XDR cartridge tests. So you don't have to wait for those results. They should be available within a few days at most for anyone starting rifampicin-resistant TB. Nobody should have to wait a month for a rapid test result to come from a reference laboratory. That's not an acceptable standard of care. And that's doable. It's right. It's with you today, and now I think that should happen quickly. So, but by and large, I think if we envision a few years from now, what would be there in Indonesia? You would have a strengthened diagnostic network of decentralized molecular tests operating in parallel with high throughput testing at central laboratories for large numbers of people, especially those from systematic screening, connected real time, so your minister could look up and see every day, every week, okay, how many people are we testing the right number of people to find them? You would increase the number of people who are getting tested by a factor of 2 to 4 from where you are today. Those results from those people would be linked to putting the cascade of services that would be required to put them on not only the treatment, but the right treatment. So the necessary DST and community services that they could help support them through care. So if you envision where you'll be in a few years, investing in the time and energy to get the diagnostic network up and running, well supervised and well capacitated, will help the country achieve its goals. Thank you very much. I'll stop there.
Thank you, Puneet. Now we go on to addressing, to discuss issues related to addressing child and adolescent TB. This will be presented by Steve. And Steve, as you stand here, please keep looking at our MCs because they will be timing you. You have strictly 10 minutes.
Thanks very much. I better get going. Salamat sore. And first I did want to, next slide please, but first I wanted to acknowledge the Child and Adolescent TB team who put these slides together, particularly representatives of the Indonesian Pediatric Group, Professor Finney who's there, Professor Rina, UNICEF and USAID, Vivian, so thank you. And also yesterday for the peer review that we received, the feedback we got from the wider group, so thank you very much. The issue, the context for child and adolescent TB is that we have the political will to address it, and I think we have the very satisfactory guidelines were developed in 2016 with intention to update those guidelines for which funding's already been acquired, and they will include some of the new WHO updated guidelines. And they've been followed in the past by training of trainers, and that's sort of about where it stops. There is good engagement of paediatric leadership in child TB, and you can see it in the quality of the inpatient care at the referral hospitals. But the challenge, of course, in child and adolescent TB is always that the maternal and child health sector and the TB sector tend to work rather separately, and what we have to do is bring it together and work in partnership. So there's a good diagnostic approaches, not being used, of course, again at the decentralised level, but certainly it's developed. We know that of all the subgroups for treatment outcomes, children do better than anyone else. There's child-friendly formulations, but they only do better if they get diagnosed and put onto TB treatment, and that's your challenge. We have lots of very child-friendly preventive treatment options now, including 3RH and 3HP, so shorter regimens and child-friendly formulations to go with that. And generally there's been high BCG coverage. I know that child immunisation has taken a hit with COVID, but generally the BCG coverage has been good. Next slide, thanks. So the challenges, I guess, in some ways might be highlighted by this slide, which shows the wide range of child TB notifications, where in Papua you have a high number of children being put onto TB treatment and notified. That's an area that's high TB endemic and also has a high proportion of its population are actually children. And there are some strong best practice work going on there. But then you have Yogyakarta, where you have a large proportion of caseload is child TB, and there's concerns there about overdiagnosis, certainly in some hospitals. And then you get down to many other settings where you have far too few children being diagnosed with TB. And the uncertainty there is, are they not being detected and treated? Are they being detected and treated and not notified, or are they just not being detected and treated at all? And this is a challenge. Next slide. So the low notification of not just child TB, but also extrapulmonary TB has a very similar pattern to that previous slide. Very variable across the country, but generally very low. And as you know, children generally contribute quite a lot to extrapulmonary forms of TB. And there's variations, of course, in diagnostic and notification practices. We don't know much at all about management of children in the private sector. I think it's common, but really it's not at all well documented. And there's no effective translation of the policy, as I mentioned, to that decentralised level of care. And that's a big challenge, is the lack of socialisation. You've got the policy, it's the policy practice gap. It's strengthening diagnostic capacity with tools and SOPs at the Puskesmas level, which is the main focal point really for provision of TB services. Not for children at the moment, but still should be. And there's very low detection of drug-resistant TB. There's very low implementation of TPT for most high-risk groups, including child TB contacts, who really should be a no-brainer for TPT, integrated with case finding in a household. And one of the reasons seems to be a lack of knowledge, a lack of understanding as to the benefits of TPTs, certainly maybe some unfounded fears about the safety of TPT and what problems it might cause with emerging resistance. That's a big issue to try and tackle, and there's a whole presentation on TPT. And there's no particular attention being given to TB in adolescents or indeed pregnancy-related TB, and they're both high-risk groups. In young children, we worry about TB causing morbidity and mortality, which is very important. In adolescents, we should also worry about TB being transmitted in the community. They're a very social bunch, and they frequently have bacteriologically confirmed TB in congregate settings, mixing widely, and so they are an important group for transmission as well as disease morbidity. And the impacts of TB in pregnancy are on the fetus, are on the newborn, are on the mother herself, and yet it's a very challenging group a very vulnerable group, but also a very challenging group to tackle. Next slide. So finally, these are our recommendations. To start with, we need to reinstate a child TB working group national level. It seems to have become inactive, but also to move such a model to the provincial level, and not just engage the paediatricians in the TB program, but a range of stakeholders and NGOs and community, etc., and defines what the objectives will be and what are going to be the outputs. Put it into a time frame. They need to follow the guideline update with a series of trainings, and we need to specifically support bacteriological confirmation, such as the use of stool with Expert Ultra, but also the importance remains of clinical diagnosis and chest x-rays widely used for the diagnosis of TB in children. We have new treatment regimens to choose from, shorter regimens. We have new regimens for TPT. And so these are all important, and they should be active at the primary healthcare level, not just at the big central hospital with passive contact management. So decentralising services is absolutely critical, and any child detected with TB needs to be treated and notified. Any child treated with TPT should also be notified to the program. And we need to socialise and integrate TPT into case finding and contact investigation. It should really be, contact investigation should be just a comprehensive package of case finding and TPT. And this should be integrated. It can be done at the community level. It can involve maternal child health workers who probably visit the households more than anyone. We do need that group working with us, as Srinivas also highlighted. There's operational research opportunities. There's a number listed there. And requesting funding, for example, for operational research, such as from the Global Fund for Child TB projects. We definitely need to engage the private sector, and I think the Indonesian Paediatric Society has a big role to play there. Many of its members work also in the private sector as well as the public sector. And we need some sort of idea as to what's going on in terms of TB services for adolescents, for pregnant women, and developing a network of professional organisations that provide antenatal care and maternal and child health. Thank you.
Thank you very much, Steve. You are on time. I didn't see the red flag go up, which is wonderful. Thank you. And I hope the next speaker will also be on time. We will now welcome Vinette to come and tell us about care and treatment for TB and treatment support. Remember to look at that table to see how many minutes you have.
Okay, thank you. Salamat sore. And yeah, so far you have heard of how to find more cases, more patients, and among which populations. But once you have found so many patients, what's the real purpose? The purpose is to cure them of the disease. And this particular section of the presentations talks about the same thing. The overall theme, I would say, here is that for all patients who have been detected, we put them on treatment early, we put them on right treatment, we put them, when we put them on treatment, we support their treatment adherence, and we create environments so that the treatment, if there is any adverse event during the treatment, we take care of it. So a patient-oriented treatment or a people-oriented treatment approach is what this presentation is going to talk about. Yeah, so this first slide provides you the context. There are 4 graphs here. You all know them very well, but the reason for putting them here is to just talk about the key messages coming out of these 4 graphs. The first one, top left, is the treatment success rate for drug-sensitive TB, which has been, like, I would say, good, not very good, hovering around 85, 86%, declining to 82% in the most recent year. But this is less than 90%. And just below that left top trend line, there is a graph which kind of splits the treatment outcomes. And if we see the biggest space occupied is by the orange bar, which is treatment completed. The blue bar below is treatment cure rates. So we see the key message here is that the cure rates are not so high. It's the treatment completion rate which is compensating. And probably we don't have enough sputum examinations during the follow-up. The right side, we have a graph. Just wait. The right top is drug-resistant TB. The good thing to see here is that treatment success rates are rising, although they are still far from what would be the ideal. And if we see the component bar graphs below, there are 2 main reasons why your treatment success rates are not high. One is those who are lost to follow-up, that means who cannot adhere to treatment for whatever reason, the red component, and the green is for those who have been, who have died. Oh, sorry, I think it's the other way around, but whatever. So these 2 are the major components for the adverse treatment outcomes. So let's keep that in mind. Move to the next slide, please. Okay, I think there has been a change in format, so the heading has disappeared. Previous, please. Yeah, we keep it here. So there are, like, this slide is for comparison of 4 provinces that were visited. We see that not everything is uniform across all 4 provinces. To highlight that intermittent treatment regimen, it's still going on in Yogyakarta, at Puskesmas level, in North Sulawesi, in military hospitals and some selected sites. North Sumatra and West Kalimantan, it wasn't reported. The treatment success rate in Jogja is 82% for drug-sensitive TB. But for others, it's like at reasonable levels of 91%, 89%, 86%. One of the important areas that we've always discussed is how many DRTB patients getting enrolled. So in Jogja, for the most latest cohort, it has reached 96.7%, which is commendable. But others, it's 84%, 62%, 83%, so that needs improvement. But the success rate, treatment success rate amongst DRTB patients is consistently low, 61% for Georgia, but others it's around about 40%. The other good thing which we have seen across all 4 provinces is the availability of patient support. So in 2 of the 4 provinces, there was global fund support as well as district and village level support for DSTB and DRTB patients that we'll come to later. And for 2 other provinces, it was being provided through the global fund. Next slide, please. So overall, the major achievements, what we can say is that for drug-sensitive TB, the country is transitioning to daily regimen. So this is a good thing happening. Category 2 is mostly phased out. So mostly is a keyword here. Then the team visiting North Sumatra observed the video observed therapy, which would replace the direct observation. So it's making the treatment more patient-centric and patient-oriented. There is a use of all-oral shorter regimen for DRTB patients, which is being prioritized. But all-oral longer regimen is also there, which is a good thing to happen. There is a move towards decentralization of DRTB services and providing ambulatory care. The country has guidelines for isoniazid-resistant, that's the monoresistance TB, and pediatric DRTB guidelines. So in many countries, this is not existent, so this is a good achievement. And this is all in alignment with WHO recommendations. There are multiple initiatives, including those from organizations of people affected by TB, which are emerging to support and promote patients' adherence. As I said, this is an important component. Patients with DRTB receive 600,000 IDR per month through the Global Fund support. And in some places, we observe local government support for TB, which is for IDR 300,000 for drug sensitive and 600,000 for DRTB patients completing treatment. Next slide, please. Some of the challenges, I'm sorry, because of some formatting issues, the title of the slides has disappeared, but these are the challenges. There's still continued use of intermittent regimen for drug-sensitive TB in some facilities. And the phase out of this regimen actually is dependent on the local production capacities. So it's like, a trade-off between purchasing local drugs, supporting local industry, and what kind of regimen can be given. Follow-up smears are not done in several sites visited. So this is an observation that supports the findings from the data which I projected earlier. DRTB treatment initiation is not fully decentralized, although the footnote says how much the country has progressed. Delay in treatment initiation, specifically when the gene expert site is not within the same facility, there is high initial loss to follow up, and in several cases, DRTB patients need to stay in hospitals. The hospitals, it was observed, do not systematically record and report adverse events, and the low treatment success rate for DRTB, as I mentioned earlier, attributable to high loss to follow up on treatment and high death rates. Next slide, please. So the recommendations from the team are to end procurement and use of intermittent treatment regimen for DSTB as soon as possible. Capacity building at subnational level for intensive monitoring. There are some recommended activities like MICHA to triangulate data, monitor adherence, and early action during initial and on-treatment loss to follow-up, and to ensure follow-up sputum testing. Use of messaging services like WhatsApp to reduce delay in treatment, initiation after diagnosis, and to reduce initial loss to follow-up. Improve systematic monitoring and recording of adverse events at hospitals, specifically for DRTB management, and some of the activities would include clinical audit, monitoring SITB, and feedback from BPOM when adverse events are entered in the system. Mainstream policy and continue the current package of treatment adherence support for patients. The last slide now. Yes. So, and systematic capacity building for case manager and patient supporter, including a to-do checklist. Further decentralization of MDR TB treatment and care to post-Christmas levels which have the capacity. So we're not recommending at all post-Christmas, but where the capacity is there. Additional support for hospitals to undertake public health activities, specifically those in the private sector. Promote use of digital technologies like telemedicine, video observed treatment that we've seen in one province for decentralization and making the services more people-centric. Roll out shorter treatment regimen for child DSTB. Now that's recommended for not complicated TB among children. You could use 4 months treatment. And plan and decide transition to BPAL-M and BPAL regimen for DRTB. So thank you so much. That's all about the treatment.
We have planned an interlude after the following presentation so that we can all take a breather. But the next presentation is on social protection and is going to be presented by Ibu Thea. Ibu Thea, you have 10 minutes. Please keep looking there. They will guide you if you are beginning to run out of time.
Selamat sore Bapak Ibu. Oke, boleh slide-nya? Terima kasih. So I'm gonna still present in English. So from this JEMM review, we have a new topic on social protection. And I'm presenting actually on behalf of Ernesto Jaramillo from WHO. So the context of this situation is that Indonesia have social protection system that includes contributory schemes such as BPJS Kesehatan and BPJS Ketenagakerjaan for the human workforce, and also non-contributory schemes such as bantuan sosial. And there are various types of these non-contributory schemes. And from the visit, Mr. Ernesto observed that the government is committed to end the TB epidemic through the WHO NTB strategy, which includes social protection and poverty alleviation, which relates to the 3 pillars in the NTB strategy. And we learned from the experts in the country that a comprehensive and effective package of social protection for MDR TB patients was successfully piloted in 2009 and 2010. And that package includes financial support for nutrition, communication, and other miscellaneous costs for the household affected by TB. And the progress now is that the presidential decree on TB already calls very clearly in the article within the presidential decree that social determinants should be addressed with social protection, and there needs to be a coordination between the Ministry of Health and the Ministry of Social Affairs and the other relevant ministries. And recently, in 2022 and 2021, there's new studies, the National Patient Cost Survey, and a qualitative study on DRTB patients' access to social protection, which have provided evidence on the magnitude of catastrophic costs and the ensuing increased vulnerabilities. So when people are affected by TB, whether that drug-sensitive or drug-resistant TB, it increases their vulnerabilities to poverty. Yeah. And from the field visit, it's very obvious that there are charities efforts from religious groups, but also foundations that provide social and nutrition support to TB patients. Next. However, from the National Patient Cost Survey, it is found that 78% of them DRTB and around 30% of drug-sensitive TB patients' household still experience catastrophic cost. And this still happens also in the context when the country uses enabler financing, which is supported by the Global Fund. And this enabler only covers for transportation allowance, which is very different from the pilot that was done in 2009 and 2010. So around 600,000 rupiah per month, and it seems that it's way from adequate. And unfortunately, there is not yet in place any intervention in the country to achieve the WHO and TB strategy target of 0 TB family catastrophic costs due to limited funding. Because during 2009 and 2010, the amount of DRTB patients who received support in the pilot, there were only a few hundreds, but now there's estimated like 24,000 MDR-TB patients in the country, so resources get more stretched. And, sorry, can you go back to the previous slide? Yeah. And the registration system for health and social services are not linked. So it's difficult for people with MDR-TB or drug-sensitive TB to be facilitated and to be connected with the government social protection schemes. So therefore, the recommendations are, the first is to conduct a baseline assessment of the social protection services suitable to cover the needs of TB-affected people, and especially we need to consider the socio-economic, demographic, and cultural context, such as age and gender, on the types of social protection mechanisms needed and who will receive this support. And the second is for a regular coordination meeting between the Director General of Disease Prevention and Control in the MOH and Director General of Social Protection and Security in the Ministry of Social Affairs to align mechanism to implement the presidential decree on TB, because there's already quite an obvious statements in the decree. And in the context of the forthcoming UNGA TPHLM next year, which will happen in September, the MOH is expected to collaborate with cross-ministries, such as the Coordinating Ministry of Human Development and Cultural Affairs, Ministry of Social Affairs, Ministry of Finance, and Ministry of Planning and Development, to develop a specific targets on social protection with clear lines of responsibilities and accountability for each parties, including in health and beyond health. And lastly, it is known that Indonesia is the most giving country. It's according to the Charity Aid Foundation. And there are 4 TB stakeholders, whether that's at national, subnational levels, could leverage crowdfunding and other public fundraising activities to support TB care and prevention efforts. Yeah.
Thank you. Thank you, Ibu Tera. At this point, we want to, for the next 10 minutes, 15. Okay, for the next 15 minutes, we can receive at this point comments, inputs from those of you who have had these findings and recommendations, if there are any. This is good. So then in that, I think there are people online. Let's just
check if there are people online who answer questions.
And they could put their questions on the chat if it's going to be difficult to vocalize them, so we can read them out.
So just, sorry to interrupt you, Dr. Chake. So there will be no specific time for the coffee break. So if anyone wants to get some coffee, feel free to get them outside and fetch them quickly and get back in so you don't miss not much of the action. Thanks.
But if you've been sitting all this time, please, just stand up for a minute or so and stretch a little bit, then sit again. You're allowed to do that.
So there is one question through Zoom chat room. We are going to showing to you right now.
Can you read it out? Just read it out and we will see who it is. Yes.
So this is from Suharna, from District Health Officer in Yogyakarta, asking about the simplification of the SITB must be done gradually to minimize lot of input data. For example, close contact or household contact that have no TB symptom. What for to be inputted to the SITB? One index is equal to 12 contacts, one suspect among 20 contacts, and what for to input 19 non-suspect to SITB, lost time and other resources. That's the comment for the from the District Health Officer in Yogyakarta.
Thank you very much. I think that's really a comment rather than a question. And I think the suggestion is well taken. I think when we are doing our narrative reports and mentioning the health information system for TB, we will include those kind of things. Thank you. All right, I suggest that you actually physically go out, get your coffee and come back because there are no questions. That will help all of us to get what some people in some countries call bio breaks. So let's give that only 10 minutes, please, and we will time you and we'll crowd you back after 10 minutes.
Ladies and gentlemen, we will start and resume in 2 minutes, so please be seated if you've already got your coffee from outside, so we can continue the session as soon as possible. Thank you.
Everyone, please come inside to the rooms since we are going to continue the session soon.
Ladies and gentlemen, we will begin the session and resume the presentation now, so please be seated. So to resume the presentation, I welcome back again Dr. Chakaya to moderate the session. Thank you.
Welcome back. Thank you, Costain. Can we have the next set of slides, please? We are going to be listening to the findings, recommendations, observations, and recommendations now from Community Rights and Gender. Who is presenting CRG? So let's settle down and listen to James to present to us our CRG. And again, they are timing you, James.
So I'll set a timer on my clock just so that I can stay on top of this as well. And because this is I think this is a topic, Annie, come up here. One thing that's important, I think, and it's a good principle for all of our TB discussions, like if we're talking about TB, we're talking about people affected by TB, their experiences accessing services. We need to make sure that we have TB community as speaking roles, and when they speak, not just about their story, but actually giving that inputs and feedback and providing space to do that. So I'm really happy Annie has agreed to present with me today. So it's wonderful as well to acknowledge that there are a lot of members from TB affected community and from civil society who have been part of this review process. So I think that that's, one of the, can I change slides? Or do I say next? I'll say next, yeah, okay, perfect. So then just to sort of say, it's to set the context. I wanted to use a little bit of time here just to discuss a little bit about community rights and gender, what it is and why we're talking about it. I think a lot of people in the room have heard this before, but I know that there's people online listening who are maybe from outside Jakarta, and so I wanted to just make sure that we use this opportunity to really unpack this a little bit for them. So firstly, when we talk a lot about things like finding the missing people with TB or meaningful engagement of communities, it's good to understand a little bit around what it is that we mean and why we're talking about that, or what are the challenges that we face in order to do that effectively. Now, one of the things that we know is that people can experience barriers when they try to access TB services, to access prevention, to access diagnosis, to access treatment. We know that things like, we've known for a long time, anecdotally at least, that things like stigma and discrimination are a challenge for people with TB. But we've not necessarily had documented evidence of this. So this is also one of the things which I think, I'll say next, and then I'll refer back to this. Next slide, please. And then one of the things, though, that we do have now is we've undertaken processes which have been led by TB community, TB civil society, in partnership with the national program to document this evidence. And I think that that's critically important and something that's to be acknowledged and to be applauded. This includes the TB community rights and gender assessment, the TB CRG assessment, the drafting of a TB community rights and gender action plan, the TB catastrophic cost survey, among other things. And the reason, though, that this is important is it's building the evidence base so that we do understand what these barriers are and how we can overcome them so that we can find the missing people with TB and ultimately achieve Indonesia's targets to end TB. Some other notable achievements here include the fact that community-led monitoring has commenced. And community-led monitoring is really important just to understand what this is briefly. It's users of services documenting or monitoring the quality of those services, documenting and monitoring the access to those services, and any barriers that inhibit, prevent them, or make it more difficult for them to access those services. It could be things like a drug stockout. It could be the opening hours of a service. It could be the distance to travel. It could be stigma. It could be discrimination. So I think that that's also something which is a really wonderful to hear, that it's progressed, and something that's useful going forward. Two other things that were noted as achievements: active case finding, contact tracing, and also some of the mental health referrals and housing support programs. So these are some of the achievements that we note. Annie, I now hand over to you for the next, looking at challenges. Next slide, please.
Okay, thank you, James. Thank you, and selamat sore. I will explain about the next slide, about the CRG community engagement, challenge and gap. So there are limited access, sensitization, and also funding on TB literacy. That we already know that the generating evidence about TB stigma assessment, they are found that 35% people with TB is facing the stigma. And also we already mentioned about James that the catastrophic cost also found that the economic burden and also jobless found because of TB. And then community-led monitoring is not active is in most locations because we know that the POP TB only exists in 22 cities and spread in 16 provinces, that Indonesia have 34 provinces. And also we have lack of gender-sensitive intervention including healthcare worker. And we also have to nuance the engagement and intervention for TB and for vulnerable population. The last is the limited communication material that can be accessible among the KVP, people who might be literate or speak language other than Bahasa. We know that Indonesia is geographical country. We have most 1,000 islands with a different language. Next, please. This is our recommendation. The first is increasing the prominence of TB-CRG in the National Strategic Plan. And then the second is to finalize and launch the Indonesia Constant TB-CRG Action Plan that will be held in, we will meet in 16 December. And then the third is enhance the meaningful engagement and participation of TB patient, TB survivor, and also key vulnerable population to scale up active case finding. And the fourth is comprehensive TB CRG literacy about human rights, stigma, and confidentiality, gender, and key vulnerable population. This is the most, I think, most of important because when I go to the field, before this JEMM, even though they already using TB drugs, when I asking them, do you know what sick you have? They say, no, I don't know. I just asking to drink the medicine until the period of time. So they didn't explain it about what is TB is and why she have to drink the medicine. Okay, the last one. This is a strong and sufficient financial support for the network TB affected community, TB survivor, and also civil society. Thank you so much for the time reminder.
And thank you, Annie. And I think just to help link this back with the first slide around the context and the next step, and again, I guess directing this to the people who are listening online, because you have such an important role to play to help operationalize these sorts of recommendations. And it will be really important to understand the support that you will need in order to be able to do that effectively. So just a couple of quick points here as well to add. I know number 5 was around demand generation. And one of the pieces of feedback that we received from peers before was also on issues such as TPT, so like around prevention, and seeing how we can leverage community and help strengthen community, but to also advance that advocacy. And this is something that's clearly a critical priority here. On the other 2 areas which were, I guess, focused on in these recommendations, a TB-CRG action plan is a collection of interventions with costings, with M&E frameworks that can be, part of your NSP or linked to it, and will ensure that you're set up well to insert those straight into a Global Fund funding request. At the moment, we know that there's very small budgets for TB-CRG in Indonesia when compared to HIV for CRG in Indonesia. So there's an opportunity to increase this, and this will ensure that you're well placed to enhance that investment. For community-led monitoring, it's going to be critical for all the partners and the people in the field and in provinces listening online to have partnerships between you and between TB communities so that you can build these effective feedback mechanisms, that you can identify problems, respond to the barriers when they're raised, and I guess leverage community-led monitoring for broader community engagement as well. With that, I hand back Dr. Shakai. Thank you so much.
Okay, thank you. Thank you very much. I think you stayed within time, which is wonderful. Now let's move on to TB preventive therapy and IPC, and this is going to be presented by Eric.
Okay, selamat sore, everybody. I will continue in English, of course. Let me see, where are we? Okay, somebody is doing this for me already. I will say something about the context for TPT and IPC is more of the silent chapter in the National TB program. Since the last JEMM, not much has moved. So that is quite, I think that's the main message. And it needs to be really accelerated. The context is that the last JEMM recommended rapid expansion. It is, they say TPT was identified as one of the 6 interventions to bring down transmission in the country that was modeled. Then we have supportive presidential decree, but the performance lags behind the ambition. Next slide. Oh, I can do that. Yeah. I split it in two parts, TB preventive treatment on the one hand, and then infection prevention and control on the other hand. So the progress is that basically TBT is a priority strategy. There are updated guidelines. The approach is the TPT cascade from eligibility up to enrollment and completion. There are tuberculin skin tests in some of the facilities, yes or no, covered by insurance. There are ongoing efforts also to digitize data collection, but the challenges are huge, very big. I mean, the coverage is really very extremely low. As I showed in the beginning, it is only 1% according to the EPI review amongst household contacts, and it is far under 5% for people living with HIV. And that is, I think, in this time and age, actually unacceptable. So there is an issue of TPT hesitancy that is not only amongst the people who are, eligible to take TB preventive treatment, but also amongst health workers to actually advocate it to these people. What I already said, the testing for TB infection is done here by tuberculin skin test for the time being, but that is not available. And Biopharma, who is producing it, is not producing it until next year, and we don't know what quantities. Then there are data entry problems, the availability of the various shorter regimens is varying across the country. Where's my timer? Oh. The recommendations, number one, is just expand TPT massively amongst all the people who need it and integrate it better in the active case finding efforts as was spelled out by Professor Ken, and then use that hand in hand. Also, in that process, make use of the portable chest X-ray and possibly tests, skin tests. Then the second one is socializing this whole approach amongst Puskesman primary care line workers, because that's where it belongs. It is, next slide please, this is not working, I do something wrong. If it comes to infection prevention and control, IPC, then the good things are that there are guidelines in terms of it is always divided in administrative controls, environmental controls, and respiratory controls. Now, concerning the administrative controls, there is a triage of patients early on in the health system, attendance to patients. There are rapid tests available, much more than before, as was demonstrated in the lab presentation. There are signs of one-stop services for TB and HIV. Sputum collection is done outdoors, and people are increasingly using surgical mask and cough etiquette. Now, I think that the surgical mask and cough etiquette is not so much to the credit of the NTB program, but rather COVID-19 and the whole country shrouding itself in masks. Environmental control, basically using natural ventilation and respiratory protection, again, the masks. One of the important things is that most hospitals where we went do have IPC committees and do monitoring of infection control and prevention and control, sorry. The challenges here is that not in all places the chest X-ray and rapid tests are in use. That is not a full coverage yet. Then the environmental controls is not in all the places where we were, there was a good ventilation. So that is something that is quite easy to address. And importantly, there was no assessment of the compliance of health facility with IPC policies. That is something that needs to be monitored. This is not only for TB, it is also for other antimicrobial resistance problems. This is cross-disease. Then, in terms of respiratory protection, the N95 respirators, how many people do I see here with N95? Probably about half. I hope there's no TB patients in that case amongst our public. But this needs to be increased, especially for health workers. Then there's a shortage of staff trained for infection prevention and control. So the recommendations coming from that is strengthen the administrative control in health facilities and more support for healthcare staff concerning infection control, and implement an annual screening for TB and TB infection for all health workers, not only the health workers that are handling TB. Next slide. And then we remain with two operational research questions, namely, yeah, I'm ready. Which key interventions are best suited to overcome and behavioral and other barriers to start TPT? So this is addressing hesitancy, but also other barriers. So to be able to come to interventions, you first need to know what the problem is. So you need to analyze and identify what these barriers actually are and why they have become barriers. So the second operational research question would be, what are the resource requirements in terms of money, people, to implement more accurate screening and diagnostic algorithms for community-based household contacts in the local context, because remember, I mean, Papua is not Java, is not Sumatra, is not Kalimantan. It's really important. I forgot Sulawesi and a lot of other islands, but I mean, big country, many cultures, local contexts. Yeah. Thank you. That is for listening.
Thank you very much, Eric. And now we move on to getting to understand what it will take to carry out all these many recommendations and activities that the JEMM and the NSP and the funding request to the Global Fund and many more will require. So we are going to get the findings, recommendations from the JMM on human resources for TB from Park Andreas. I hope I have pronounced your name correctly.
Okay. So, good afternoon everyone. Selamat sore Bapak dan Ibu semuanya. Kita masuk ke satu tema yang sangat crucial, yaitu sumber daya manusia. So, we would like to present about the human resource thematic report. Next, please. So, this is the context that the presidential decree demands the quantity and the quality of HRH. Seperti Bapak dan Ibu ketahui, untuk yang berkait dengan peraturan presiden ini membutuhkan tindak lanjut di daerah. Oleh karena itu, daerah harus bisa menerjemahkan regulasi ini menjadi satu sistem. Dan we have a lot of new intervention and targets that will be set up in the upcoming National Strategic Plan. Bapak dan Ibu juga ketahui bahwa National Strategic Plan kita untuk TB akan segera dikembangkan Dan ini salah satu implikasinya adalah pada perubahan di sektor human resource. And the constraints, kita melihat bahwa the HRH staffing model ini ada diskrepansi Bapak dan Ibu dari temuan-temuan kita, terutama pada aspek quantity dan quality. Dan kita lihat ini tidak hanya terjadi di fasilitas pelayanan kesehatan atau di komunitas, ini juga terjadi di level program management. And in all level, we have this kind of discrepancy. And capacity issues, Ibu dan Bapak bisa melihat bahwa selama ini ada pelatihan-pelatihan. We have national design training program, but then the cascading activity kind of not in place. Jadi kadang-kadang di daerah Bapak dan Ibu menerjemahkan pelatihan yang ada dari pusat ini bisa berbeda-beda, dan kita tadi melihat bahwa budget yang dialokasikan untuk pelatihan ini lebih banyak untuk akomodasi dan juga transportasi daripada pengembangan konten. Dan kita menemukan juga bahwa TB officers ini di lapangan statusnya juga beragam, ada yang kontrak harian sampai dengan ASN. We also found, Bapak dan Ibu, ada multitasking TB officers, ya, memegang program banyak sekali, dan terkait dengan kegiatan-kegiatan di puskesmas yang sangat banyak, maka ada beberapa hal yang harus mereka pegang, beberapa program, dan kadang-kadang ketika ditanya berapa alokasi waktu, time allocation untuk TB, ini tidak terlalu jelas. Dan juga isu proteksi tenaga kesehatan, bahwa kita tahu ada temuan-temuan ketika fasilitas pelayanan kesehatan melakukan screening, ditemukan petugas kesehatan yang terkena TB. Demikian juga dengan di level komunitas, tapi bagaimana sebenarnya mekanisme proteksi ini belum terlalu clear. Dan we come up to the recommendations. The next slide. No, this is the information about the staffs who work for TB. Bapak dan Ibu lihat di sini, di Central Unit itu ada 13, tadi sudah direvisi oleh Bu Tiara, ternyata hanya 11. Ya. Dan harapannya kita akan segera meningkatkan ini, karena ada rekomendasi bahwa dari India ini ratusan stafnya. Ya, next slide. Ini data yang menarik. We have recruited TB officers dengan bantuan Global Fund, tetapi Bapak dan Ibu bisa melihat di kolom paling kanan jumlah yang aktif dan jumlah yang dilatih ini ternyata jauh sekali. Jadi kebutuhan-kebutuhan di lapangan diusahakan untuk dipenuhi, namun bagaimana kompetensi mereka, termasuk juga kemampuan-kemampuan tambahan untuk menggerakkan program TB ini masih kurang. Ini oleh karena jumlah yang dilatih dengan yang direkrut ini ternyata jauh berbeda. Next slide. Dan kita masuk kepada rekomendasi. Kita perlu melakukan rapid assessment. We have changed this point. Bapak dan Ibu perlu melakukan rapid assessment dalam waktu 2 sampai 4 bulan agar kita bisa mengidentifikasi kebutuhan SDM, baik itu kualitas dan kuantitasnya, dan kita perlu juga melihat bagaimana perencanaan SDM baik di pusat maupun di level fasilitas ini bisa kita kembangkan. Dan juga kita perlu ada standar kapasitas dari SDM. Sebenarnya SDM yang bergerak di program TB ini, bagaimana job specification-nya dan juga job description-nya, TOR-nya ini harus sangat jelas, karena mereka memegang satu program yang sangat strategis dan dimonitor secara internasional. Dan kita juga memahami bahwa selama Bapak dan Ibu memegang program ini, ada banyak obstacles, ada banyak barriers yang ini tentu harus diselesaikan baik secara pelatihan dengan cara pelatihan maupun pendekatan-pendekatan yang lainnya. Dan juga kita melihat ada perubahan desain dalam bekerja. Kita harus melakukan redesign untuk pekerja-pekerja yang ada di program TB ini, termasuk aktivitasnya supaya menjadi lebih efisien, menjadi lebih efektif dengan tadi pertama memastikan job description, kemudian persyaratan-persyaratan jabatan, kemudian memastikan bagaimana hubungan kerjanya, dan juga yang ketiga bagaimana performance management itu diterapkan termasuk berkaitan dengan insentif. Bapak dan Ibu, kita dari sisi quantity juga merekomendasikan bagaimana supaya workload staffing needs yang rutin ABK yang sudah Bapak Ibu lakukan setiap saat di lapangan ini bisa digunakan untuk menghitung kembali kebutuhan tenaga. Setelah itu kita juga harus memastikan bahwa SDM, human resource yang menggerakkan TB ini dihitung dari semua sektor, tidak hanya dari sektor publik tapi juga private sectors dan juga partners. Berikutnya kita juga harus mengubah pola hubungan dengan kader, karena health cadres kita saat ini masih bersifat sosial. Kita tentu tidak bisa men-setting standar kinerja dan juga target-target oleh karena tidak ada hubungan yang formal dengan fasilitas pelayanan kesehatan. Dan kaitannya dengan kualitas, kita meredesain program training, ada training need assessment, dan training ini juga berkait dengan training leadership di level atas, sampai dengan training teknis yang bisa memastikan kapasitas dan kapabilitas dari SDM di lapangan itu sudah memenuhi persyaratan. Bapak dan Ibu, kita juga mengusulkan supaya ada log activities untuk menghitung kegiatan-kegiatan SDM, terutama untuk menghitung berapa time allocation yang mereka siapkan untuk program TB. Dan kemudian juga ada program surveillance dan screening untuk tenaga kesehatan di level fasilitas pelayanan kesehatan dan juga di level komunitas, terutama health cadres, untuk menjaga agar mereka aman dari pajanan kuman TB. Dan ini sangat penting Bapak dan Ibu karena kita sangat membutuhkan tenaga kesehatan yang betul-betul sehat dan produktif untuk menggerakkan program TB di lapangan. So I think this is all from the human resource report, and thank you very much for your kind attention. Thank you.
Thank you very much for that presentation. Now we move on to look at the issues that are related to embedding tuberculosis responses into the UHC agenda. And to do this will be Babis. You have the floor.
Great. Hello, everyone. It's a pleasure to present the findings on this theme on behalf of the JEMM. Next slide, please. It's not working. All right. So we have grouped the presentation, the findings, and the recommendation into three themes. The one around health system transformation, the digital health transformation, and then finally around everything around the presidential decree number 67 for to end tuberculosis. So in terms of the context and the health system transformation, a lot has changed since 2020, and in fact, it is a very exciting time for TB prevention and care in Indonesia. So we're currently in the midst of a comprehensive health system transformation to improve population health outcomes based on the transformation of 6 pillars: primary care, secondary care, health system resilience, health financing, health talent, and health technology. TB services are included in the essential health service package, and they are covered by the National Social Health Insurance, JKN, and JKN coverage is more than 90% of the general population in Indonesia. So these are all excellent messages and excellent progress. Furthermore, there's been an agreement signed in August 2021 to link the data between the BPJS health information system and the SITB health information system. And while this has not been implemented in the best way possible because it still requires manual entry of ID codes, it is an excellent start. And then finally, there are some new guidelines for Pusanto Prima, which now include TB screening investigation. So we're taking TB screening at even the lower administrative levels. In terms of the digital health transformation, we have seen the blueprint for that, which provides a very ambitious and at the same time quite considered overhaul of the digital health transformation in Indonesia and simplification of data entry. So really there's a lot of consideration about the workload of the frontline workers, and that is being described and is very well addressed in that blueprint. We're aware there is currently very close collaboration and coordination between the digital transformation team and the National TB program, which is excellent news because, of course, what we want is for DTO to really also work for the TB program and TB patients. And there have been major improvements in the quality and coverage of SITB since 2020. Also, quite a good message is that mandatory notification of TB, the legal frameworks are in place, and it is already being endorsed among health facilities that are BPJS facilities, so they receive funding only when they report data on TB patients. And then there are some data linkages that are now being established between SITB and the large hospital networks built using the SIMRS software. And then finally, around the presidential decree, we've already talked about this. This is really showing the highest level commitment at national level to end TB by 2030. Next slide, please. In terms of constraints and gaps, there are major gaps that have been reported on HR staffing needs and capacity for health, particularly in the Puskesmas level. We also feel that there are some missed opportunities to strengthening the public health function of Puskesmas. For example, there is a regulation that prevents positioning chest X-ray machines in Puskesmas, and this is a missed opportunity for screening for TB and other relevant activities, of course. And also, there is still no agreement for data sharing and carry out record linkage between BPJS and SITB historical data, which once again is a missed opportunity to better inform our understanding of the trends in TB burden. And then finally, there is no mechanism for providing JKN eligibility for people with presumptive TB and people with TB disease who do not have JKN membership when they start treatment. And then under the digital health transformation theme, some of the constraints include the lack of clarity and on the timelines and transition plan for SITB. We don't quite know yet whether SITB will be dropped or whether it will be subsumed within the overall, whatever it is that emerges from the completion of the digital health transformation. If SITB stays, then we need to implement urgently improvements For example, there are very slow processing times for data entry, and that really leads to underreporting of people with TB everywhere, but also the private clinics. There is also a lack of clarity on the objectives of the TB surveillance system, and this is quite important because you first need to define what you want your TB surveillance system to be doing, and then based on those objectives, you define the data items that you collect at the health facility level and the indicators that you report upwards. And I think this is really important because currently under DTO, there's been a revision on the TB variables that will be collected once the digital health transformation completes, and we need to make sure that the needs of the TB program are in fact addressed by that mechanism. There is traditionally very limited data sharing within health databases and beyond health, across health databases that hold information on TB patients. And again, this is a missed opportunity because if we do manage these data linkages, we can improve underreporting, and we can rather reduce underreporting, and we can improve our understanding of TB burden. And then another quite important issue is that we have seen limited analysis, interpretation, and use of data to guide action at all levels, including the health facility level. Next slide. And this is just an example to show you the amount of information that exists out there that is not being used. If you look at the first column, that shows you the number of TB patients for whom we have information in the BPJS system. And you see, for example, for 2019, the number of TB patients that are entered into the BPJS are much higher than the number of notifications in SITB. So we're talking about a huge potential there that is not being used. Next slide, please. Under the presidential decree, the commitment at the local government level does not match the level of ambition at the national level. So this is very clear, and the implementation of this decree will be complicated given the current transformation of the overall of the overall health system and the digital health transformation. And then finally, the targets that have been used in the decree were based on our understanding of TB burden in the pre-COVID era. We know at the moment that TB burden has been affected by COVID, but we don't yet know exactly how. So we need to generate new information to inform our understanding of TB burden. Next slide on the recommendations. Okay, so under health system transformation, we are recommending to review and update the regulation that bans the use of chest X-ray in Puskesmas to increase capacity for screening for TB and other health conditions. Number two, to set up a technical group and develop methods for carrying out record linkage of historical BPJS and SITB data, importantly, ensuring the confidentiality of patient records, because we understand this is one of the reasons why BPJS was not very keen on sharing that information. But there is a way to do that. There is a way to ensure the confidentiality of records. So we recommend a technical group to look at that. And then finally, to prepare some technical guidelines on how to provide JKN eligibility for people without it. Next slide. Under digital transformation, we understand that the collaboration between DTO and NTP is there. However, we need to ensure that this continues for the duration of the implementation of the transformation agenda, and we recommend to define clear objectives for the TB program to really have a conversation and for the TB program to say exactly what they're expecting out of the digital health transformation. If SITB is maintained, we need to urgently implement improvements, such as having an IT specialist to measure system performance, such as carrying out a user assessment to improve acceptability of the system, and then also review and update the dashboards. Number 3, we're recommending to define clearly the objectives of the TB surveillance system that address all the needs of the program, and then once that is completed, then also define the data items to be collected at the health facility level. And then finally, to develop guidance and training courses, preferably in e-learning format, for data interpretation and use for programmatic purposes, and do that for all levels. And the last slide, next one, the recommendations for the presidential decree. We recommend for the Secretariat of the Coordinating Mechanism and advocacy groups such as the Stop TB Partnership Indonesia to monitor the implementation of the presidential decree for the acceleration of progress towards ending TB at the local government level, with associated regulations, HR policy and plans, and dedicated budgets. And number 2, to use existing data, and I'm giving the example of the hospital mortality data or the retrospective linkage of records across TB databases, and also generate new data, such as through a sample vital registration system or a prevalence survey, to improve our understanding of TB burden in the post-COVID era. Thank you for listening.
I want to believe he stayed within time. Very good. So now we want to move on to tell you what the findings of the JEMM were in terms of research and innovation. And it's your time now. Tell us about TB research and innovation.
So thank you. This is about TB research and innovation. So NTP of Indonesia has addressed the challenges and recommendation of JEMM 2020 in the current TB strategic plan, which spans over 2020 to 2024. So the TB strategic plan for the country for the next 4 years has 6 strategies, and one of them being utilization of research findings and technologies for screening, diagnosis, and management of TB. And the current JEMM 2022 also has one of its objectives mentioned for research activities, review the activities related to TB research and innovation. Next slide, please. So what is the current research environment in the country? We do have available a national TB research network, which has identified the priorities of research agenda for the next 4 years, 2020 to 2024, that the JET-SET TB established in 2017. The country also has identified the research agenda for the next 4 years. There's a priority listed in the thematic areas, and this alignment with the Presidential Decree 67/2021. There is also availability of local TB researchers. The capacity building opportunity for TB research also exists here, and it mostly composed of universities and research institutions. The JET-SET TB provides capacity building workshops along with dissemination of the priorities identified in the research agenda that's shown here. And their annual conference, and also which was done recently, where they disseminated these priority areas. And there is an availability of international and local collaborative research initiatives within this consortium. Next slide. So what needs to be improved? Whether do we have a regulatory processes in place to conduct clinical trials if the country wants to do vaccine trial or new drug trials? That needs to be developed. There is funding allocated to TB research, but is the funding that is allocated to research being utilized for research? If not, why is it not? Especially when there is restructuring of NIH-RD, complicating further the issue of research funding. There's a National Health Information and Vital Registration System which needs, there is a lack between the coordination between these systems which has to be fixed. Policies and practice for open access and open data for the scientific research needs to be in place. If Indonesia wants to be the leader in TB research, there are 2 other areas which it will have to work on: newer drugs, newer regimens, and vaccines, especially trials like truncate TB or newer BPAL regimens, modified regimens. So we need to build in capacity for all these activities. Next. So what is a country's vision for research? There's a role of research in achieving TB elimination target, and what is that? If you look at this graph that's shown here, the research agenda that was made in 2020 and that aims for 2020 to 2024. We're already 2 years down the line. JET started in 2021 and the dissemination has happened last year. But after 2022, we have another 2 years to complete, and these are the things that has to be moved faster. There are new skin TB testing, BCG vaccination, recombinant BCG, newer diagnostics, newer regimen. So where are we? So we need to move faster to achieve this. If Indonesia wants to move fast, then research also should move faster. Next. The constraints that have been identified and gaps identified. There is specific provision of budget for research, but there is some lag in the mechanism of the flow of budget to the researchers. Local capacity on both data collection, data analysis, and interpretation needs a little more concentration, especially when it comes to evaluation of the program. And whatever research has been done gets published, but is it getting communicated to the program managers and other health officers? So what is the recommendation of JEMM from on this pillar of research and innovation? So there's one question of, is there a magic bullet, magic research which can be done and the TB elimination achieved? The answer is no. If you remember the graph that Dr. Chakaya showed in the first place, the last line was a pink line. The pink line is the one which bends the curve and touches the horizontal line. But before that you had multiple colored lines, which includes active case finding, putting whatever diagnostics you have to the maximum use, identifying subclinical TB, putting TPT in practice, and then comes the vaccination. So it's just not one priority, but all of this should happen at the same time. It's not one after the other, and it should have in a mass mode. It's a combination of all these activities. For all that, what you need is budget. So the sponsors have given budget for the research activities, but where does it's getting stuck? So is there a specific mechanism in place of how the budget flows from the central to the province to the local districts? If not, a mechanism has to be set there for the budget flow. Focus on the priorities of the local regions. OR can be done at the local levels, multiple sites can do that, but there should be a provision of budget. If there is a bottleneck, identify the bottleneck. And if you do not have a system, the system has to be placed. One example would be an operational research cell. The OR cell could be placed at the Directorate of Disease Prevention and Control, and NTEP managers could be part of it and identify the OR and IR that is required. So not only the operational research of the downstream research, I think you should also concentrate more also on basic research, modeling techniques, or health technology assessment, health economics. These could also be part of OR research. The next identified recommendation would be capacity building. Once you've identified the priorities, the capacity to be built, not only for the research and healthcare workers, but should also be using the community volunteers or the TB survivors, TB champions, when it comes to social protection research or health system strengthening. So capacity building, and also to do proper statistics, communication of the results to the program managers in the form of policy briefs. The last would be dissemination of your research findings to the general public, and good public health practices to be practiced. Next, that's the last slide. Okay, but some of the examples where we suggested we should take forward, one was the active health case finding that's happening in multiple provinces and districts. The results that has come out of them could be easily compared to see which particular model is giving you the maximum yield of case with a minimal input of a budget involved in that. And this result could be successfully replicated in other districts and provinces. Health system research, for example, would be how to leverage the universal healthcare payments to improve the performance. Increase the testing of, using the local RT-PCR testings to diagnose more TB instead of depending on the cartridge-based techniques. One thing that has been highlighted is mortality reductions, operational research to find the cause of mortality, the delay in patients coming to the system, so early identification of case to prevent death. These are few of the ORs that we could highlight. So the OR cell or the committee can decide on the local priorities and come up with these kind of suggestions. Next. I think that's the last. Thank you.
We are just about to start our descent. We've been cruising at 34,000 feet, but we are about to start descending now. And there are two important things that I think we need to pay attention to. So those of you who've been sleeping, please wake up. When I was young, as a program manager, I was told, no product, no program. And the second thing that I learned yesterday is that there are only two important things in life, God and money. So it's time now to listen to the issue of procurement and supply chain. Again, going by the mantra, no product, no program. Please, Zaza.
Salamat sore. Thank you, Dr. Chakaya. So the objective of this thematic area is, as mentioned by Dr. Chakaya, is that we need to ensure supply of medicines and other commodities in the country. And because even if we find patients, even if we are to start them on treatment, but if we don't have medicines, then we cannot progress. Okay, sorry. Just a background that the presidential decree number 67 highlights the importance of this through the fulfillment of needs of quality TB drugs necessary to reach TB elimination. The funding source for TB procurements, this is mixed. Some are from the government of Indonesia, and some are supports also from some donors. Government-funded procurement is restricted to procure from local suppliers based on policy. And currently, there is no daily regimen of Cat1 kits for the STB available locally. The STB adult transition from intermittent to daily regimen, since we don't have this locally, is planned and it's underway. And this is supported by the Global Fund. And the plan of this transition is by 2023, it will be 100% daily regimen that the government of Indonesia will procure for the country. The lead time, particularly for international procurement here, has several phases because there are several stakeholders in all this procurement. So starting with placing of orders, payment of order, production with the suppliers, and also a pre-shipment custom clearance in the country. So there are many stakeholders and players in this process. But looking only at the government process here is the pre-shipment custom clearance, which is around 2 to 4 months. And this will add up to all the lead time, which leads to a total lead time of about 1 year or 8 to 13 months. The local procurement, in addition to that, there is a new requirement that started this year that any importation has to get approval from the Ministry of Trade, and this may also add on to this lead time. The government national procurement lead time is almost the same as the international procurement, which we are looking at 12 months or 1 year. And this is also variable to the capacity of local supplier to produce. Next slide, please. In terms of achievements, I listed here sustained commitment to cover TB medicine procurements. There's also phasing out of the old or not WHO recommended regimens like the Category 2 DSTB kits and also the injectables for the RTB. So the program is already almost phasing out. There is also phasing in of new medicines and new regimens, and particularly for the short treatment regimen for LTBI. So rifampicin is included and available in the country. 3RH is also available. as I mentioned, daily regimen of DSTB is starting to phase in. New pediatric formulation for DRTB is also available. And also the all-oral regimen for DRTB is the standard regimen for DRTB now. Information system, this is particularly SITB, allows capture of data for medicine quantification and pharmacovigilance. And so this is being used for entry, and not only for entry, but there are also people, the program is also using this data for analysis, for quantification, and for informed decision. Next slide, please. There are challenges, and the challenges here is, I mentioned the plan for the transition to daily regimen. However, in this plan, there are uncertain elements. One is, as of now, there is just one supplier that is ready to produce daily regimen, and their capacity to produce the 100% requirement is also uncertain. Then there is also the need to register and include them in the e-catalog. And this is being processed right now, but this is also, we are also time limited because we need to make sure that these are all set up and established because the government procurement will start in Q2 2023. The lead time for procurement is long, requiring advanced planning of the program. There were reports of shortages from the field visits, and looking at the costs of these shortages, we have supplier incapacity or underreporting, which are the basis. We use the reports as a basis for quantification. So if there are underreporting, then we also need to adjust our quantification based on that. There is also issues in terms of inadequate funding and delay in procurement, particularly in the use of DAK, or the Special Allocation Fund, for expert cartridges. Well, for second-line drug procurement, there is limited procurement of the government because of the capacity, or there's no local suppliers. Then there's a report of shifting of patient treatment between daily regimen to intermittent. So one patient started on daily regimen and then shifted to intermittent treatment on the continuation phase. And also in the information system, which is the basis of our quantification, there's reports of slow and delay in entry. Next. So as recommendation, number one is to fully cover the treatment, the procurement of treatment and diagnosis, particularly the STB medicines and expert cartridges, with adequate buffer. The other one is to establish a PSM working group. And this PSM working group is supposedly will meet, let's say, annually or biannually, but a meeting that should be done before the actual procurement. And in this meeting, it should be a planning, coordination, and information meeting. In this meeting, we invite stakeholders to discuss and finalize the actual need. We need to also incorporate buffer in that calculation, and then also to inform the supply from the suppliers that these are the needs for the next years. Then there's the stopping of the procurement and of intermittent regimen, because we want to move very quickly to the daily regimen. Address the issue of patient shifting by monitoring, reiterating the policy, and supervision. Considering the lead time of procurement, we need to, as said, plan 1 year ahead for the program. So the program needs to decide also immediately in terms of implementation of WHO recommendations, particularly BPAL and BPAL-M, and all the other shorter treatment regimens. And also, lastly, is for to improve the data entry to the information system. It may be SITB, or it could be another TB surveillance systems based on the program. Thank you.
Thank you very much, Zaza. And now, how will we fund all this? Or rather, what is the funding landscape looking like? And what are the recommendations of the JMM for funding all these many things that we have talked about? Who is presenting between Pakpan and, okay, please.
Okay, while the crew is preparing us for landing, I'll bring you to the last presentation of the day, and this is on financing. So yes, thank you very much for putting up the latest version. This is the first slide is on the context, on the background. I think we recognize that there's an increase in TB program financing over the years, and we noted that prior to the pandemic, there's a significant increase in TB financing. It has fluctuated during the pandemic, and I think we need to be cautious and aware on the financing post-pandemic, considering that the macro fiscal situation is not very supportive, and there's a likelihood that there's a limited fiscal space for health in general, and TB has to compete with other programs. And also in terms of public financial management, we recognize that Indonesia has a very complex public financing system, and there are multiple streams of financing that flows from the central as well as external financing that works outside of the public financing system. There's different types of transfers from the central level with limited accountability mechanism. Transfer from the central are not really linked with how subnational government achieve the targeted performance. In terms of the overall TB financing, as I mentioned earlier, that there's a estimation that the gap for the financing is widened because of the decrease of performance during the pandemic. Next slide, please. Yeah, but we also noted that there are several progress or achievements. Implementation of the performance-based financing scheme, or BOK Kinerja, or BOK Puskesmas, has already started in 2021. And one of the indicators that is linked to this transfer is successful treatment of TB. But we need to push on to have an indicator related to case notification. So there's also a requirement to include TB registration number in hospital claims. There's already started. So no notification, no reimbursement. This will push or incentivize health facilities to be in compliance in putting this registration or reporting TB. BKS, Belanja Kesehatan Strategis, or Strategic Health Purchasing, the concept has been introduced, well received. It will be piloted in 2 areas. So this has started with a good start. And then drug-resistant TB code and its related grouper has been implemented using temporary code, and a longer-term solution is currently under discussion. There's a revised MOH decree on use of capitation payment that can be taken advantage to finance TB activities. Next slide, please. So those are the notable progress. Challenges, as also highlighted in the previous JEMM, there's still limited capacity in planning and budgeting. Especially this is made difficult with the unavailability of budget information or health financing information. Delays in the available of budget at the subnational level especially also prevent more efficient and effective planning. Next slide, please. The other challenges in terms of demand-side financing, JKN program payment mechanism, the existing payment mechanism creates perverse incentives, so unintended incentive that disadvantage the TB program. So there are several examples. I'm not going to go over one by one, but in principle that capitation payment discourage primary care facilities to provide comprehensive TB care and encourage them to refer up to hospital. While in a CBG payment at the hospital level encourages hospital to retain patients and to creep up as well as to repeat patient visits. So this mechanism needs to be looked at and changed. And then interoperability of information system has started now with a promising development that there's an MOU, but it's not yet materialized. Next slide. Yeah. So these are the recommendations, and as our team is looking at health financing from these two perspectives, demand side financing, which is on JKN social health insurance, as well as from the supply side financing. So on the demand side financing, the recommendation is to speed up the belanja kesehatan strategis or strategic health purchasing by including the requirements and certification of health facilities readiness in providing TB service as a part of the credentialing process of the BPJSK. So secondly is continue to establish the episodic JKN payment for primary health care. And we already link this episodic payment related to identification and notification to encourage monitoring for patient adherence to treatment and as well as to complete treatment for TB patient. But this will need extensive advocacy to raise awareness on what strategic health purchasing is. This will include analytics to show the benefits or the cost saving that BPJS will get in implementing the strategic health purchasing. And then I think stakeholders need to follow up and monitor the okay, thank you. So, crew prepare for landing. Yes, so sign MOU and data exchange need to be monitored, and capacity for at all levels to make use of the available data from the JKN program. Next slide, and this will be the last slide. On the supply side financing, we need to improve consolidation of health financing, ensure the timeliness of the availability of financing, transfers from the central to subnational level, enhance BOK kinerja and BOK Puskesmas with TB indicator that encourage TB case finding rather than TB success rate only. And then strengthen subnational capacity in planning and budgeting. So I think this is theme across all of different topics on strengthening subnational capacity. So module on planning and budgeting needs to be included in that capacity building for subnational level. And lastly, I think we need to continue thinking about increasing resource mobilization from pro-health taxes, including tobacco and SSB, that has twofold benefits, which is increasing physical space for health in general and reduce risk behavior that are related to TB. So with that, I will end my presentation. Thank you.
And with that, we come to the end of the presentations. Wonderful presentations. I thank you all for remaining awake. And I'm wondering if there's we could take a few minutes to hear inputs, comments for the second set of presentations, if you still have the energy for it. In the absence of energy for it, I want to hand you back to our MCs to see what we do next. And I really want to thank all of you for remaining awake and calm and listening to all this huge round of presentations. Thank you very much.
Thank you very much, Dr. Chakaya. Please, ladies and gentlemen, give a round of applause to Dr. Chakaya and also all the other thematic leads for the presentation. Okay, so for this session, we opened the forum for a 15-minute Q&A. So are there any questions from the forum? So we'll start with the ones that are here on the hotel. Are there any questions, probably, perhaps, that they would really be eager to ask to the team? Going once, going twice. So I think the information is very well messaged indeed. Oh, Pa Eric, okay, please go ahead.
Oh, yeah. No, of course it's not a question because I'm part of the team, but there is one thing that I realized when I was going through my notes of the very first day when I was listening to the presentations of the NTP. And one of the top priorities I put down for myself on paper was that I think that a very essential element in the upcoming years will be a proper, well worked out and thought through communication plan that acts as oil in the machine. Because we have a presidential decree, there are circulars, but somehow it doesn't get down to the levels where the interface is with patients, people, communities. And so that I think that requires a communication strategy, a professional one, in terms of a dialogue with all the different players, because I see a lot of moving parts, but it is like somebody said it this morning, it seems it's like a big orchestra, but where is the man with the small little stick to make them play a nice symphony? That is, I think, is something missing, and we did not discuss that at all. So that's I would like to give to the writers of the report and perhaps some reactions from the audience. Thank you.
Thank you very much, Pa Eric. So thank you for the inputs indeed. Is there anyone who would like to comment also on Pa Eric's comment? No? So can I check if there are any more questions from the Zoom? Oh, sorry. I cannot see. Okay, so can we check if there are any questions on the Zoom channel, please? No? Okay, so final round. Are there any more comments or questions? Doesn't need to be a question, a comment for example, input for the report later on. Please, if anyone has anything that they want to put out there. Nothing? Okay, so to continue on what Dr. Chakaya and Pak Pandu also mentioned earlier, so the plane has landed. So we have landed now at our destination, but the journey hasn't ended yet. The plane is still taxiing to the arrival gate. So it usually takes around 10 to 15 minutes just to arrive at the gate, right? So in the meantime, as we go towards the end of our journey today, I think it will be a great time for us to allow the Ministry of Health to process this information and also provide us some responses and also a follow-up action plan.
So moving right along, I think we already hear about, yes? Is there? Oh, there's one who raised hand in the Zoom. We are going to take the comments from Zoom, or we are going to proceed?
Oh, okay.
Proceed.
It's Ibu Novi from BPJSK. Please,
Okay.
we can take the question. Yeah.
Okay. Okay, we would like to invite Ibu Novi from BPJS to deliver your comments. Please, the screen is yours. Oh, can you speak a little bit louder, Ibu Novi? Ibu Novi, can you speak a little bit louder?
Okay, so I'm guessing Ibu Novi got kicked out of the Zoom, am I correct? Was that intentional? Oh, it's already on. Okay, we'll wait for a few moments.
Let's wait a couple of minutes to wait for Ibu Novi to joining in. Okay. Ibu Novi, silakan bisa disampaikan. Ya.
Izin, apakah suara saya terdengar dengan baik?
Iya, terdengar Ibu.
Iya, maaf saya berbicara dengan bahasa Indonesia, tidak apa-apa?
Ya, silakan Ibu.
Izin menanggapi rekomendasi yang disampaikan oleh Pak Babis dari WHO tentang suspek TB. Sebenarnya di dalam JKN banyak sekali klaim juga yang menggunakan coding Z03, yaitu terkait suspek TB juga. Jadi dari situ mungkin bisa diangkat juga untuk underreport TB. Hanya saja di dalam proses padan data dan rencana interoperabilitas, kode ini tidak masuk di dalam kategori karena yang dibintai oleh DTO Kemenkes itu adalah kode A15 sampai A19 saja. Itu saja yang ingin saya sampaikan. Jadi kami di dalam klaim JKN itu banyak kode Z03.0 yang merupakan suspek TB. Terima kasih.
Baik, terima kasih banyak Ibu Novi. Kita take note atas input dan komennya. So we've been heard about the insightful. Oh, okay, Mbak Ezi. Oh, Babis. Okay, sure, please.
Thank you so much for the comment. I'm hearing the translation in Bahasa in my ear. Thank you so much for the comment. I think there is again, this goes to show how much more information is there in the BPJS database and how much we can use that information to really inform the TB response. So I would say we need to put together a small technical team that sits down and look at this. Perhaps you can describe all the data that you hold in the BPGS database, and then we can review how we can use that even at the aggregate level. I think the fact that you collect information on people with presumptive TB, that's extremely useful for us to understand the effort, so the number of people who are investigated. So, and I can continue the discussion with the NTP colleagues and the surveillance team, perhaps Paxulis and others. But I really think there's a wealth of information there we can use. So please let's continue the discussion on that. Thank you.
Okay, thank you very much, Babis. Is there any more, just to make sure, the last call, is there any more comments or inputs from Zoom? Maybe the committee? Can you make sure? Is there any more who going to raise hand? No? Okay. Is there anyone in here who would like to give in more additional comments or inputs? I'll be counting. 3, 2, 1. Okay, we are going to moving right along. We've been heard about the insightful presentations that highlighting the challenges that we are still facing, and also mentioning that some of the opportunities that also can overcome the challenges. Now we are going to have a response and action plan from the Ministry of Health that will be delivered by our wonderful National TB Program Manager, Dr. Tiara Pakasi. I would like to invite Ibu Tiara to go to the stage. Please welcome Ibu Tiara Pakasi.
Okay, thank you so much, Siva and Jonathan. I think big applause for both the two MC, wonderful MCs. Now I give compliments to you. Okay, thank you so much, all distinguished guests, and also respected officials from Ministry of Health and other ministries and government institutions, colleagues from all reviewers, and also colleagues from communities, partners, semuanya, Bapak Ibu, ya. Especially to Dr. Cakaya, our team leader, and all the members of the Joint External Evaluation Monitoring Mission for Tuberculosis Control Program in Indonesia. First of all, of course, really grateful for this opportunity and for all the work that have been done these last 10 days, I think. Thank you so much for all your hard work, and you can come with wonderful summary of our progresses and also challenges and what can be strengthened or improved with regard to our national TB prevention and control program. And please, on behalf of Pak Imran and also all the NTP team, I would like to deliver the responses that we at the NTP and also discuss it with our director, Pak Imran. Some response and also maybe comments on your recommendations. And maybe later on, if some things need to be added, Pak Imran is still here, and he can add to what we have documented as response. Number one is regarding to the strengthening TB screening and active case finding by equipping Puskesmas or primary health center with digital X-ray and artificial intelligence, and also molecular testing, linkages to identify TB-associated comorbidity states, and engage more primary level private providers. With this, regarding these recommendations, we, NTP and also the whole, related units at MOH, will follow up with coordination with the related stakeholders. especially regarding the radiology placement requirements in primary health services, yeah, because at the moment I think the regulation is not yet available, yeah, for that specific recommendations. And then for the molecular testing, the good news is that we've been utilizing the molecular testing, where currently we have 1,812 gene expert machine, yeah, we call it TCM or test cepat molekular, available, and this number has increased by 96, I mean, from the number in 2020. And maybe I would like to say also that these machines were both through the national funding and also the grants from the Global Fund. We still have planned to increase the number of other tools and maybe if other methods available, yeah, focusing in primary health care. And maybe for dear colleagues who followed the brief meeting yesterday with our Excellency Minister Pak Budi, he also expects that since we are already investing in lab networks for tackling COVID-19 pandemic, and he expects or he challenges us how to utilize it for TB case finding and also how to involve or engaging with private providers. The second one regarding the strengthening TB management capacity and support system by engaging Ministry of Home Affairs for availability of trained staff and also Ministry of Social Affairs to secure social protection. We are lucky that we actually, the mandate from the Presidential Decree number 67, the famous Presidential Decree on TB, both ministries, the MOHA and Ministry of Social Affairs, are part of the National Acceleration Team for TB Response. And they have tasks to coordinate the fulfillment, both on the financing or other resources needed regarding TB control, of course, according to their task and responsibility. So we at the Ministry of Health, NTP and other related units, will continue our fight, yeah, or not fight, I mean to establish the clear guidance, yeah, and also how to fulfill this the needs of human resources together with the MOHA, and also maybe, of course, we need support also from our colleagues in the community or other maybe universities and other institutions on coordinating and reinstate, yeah, the social protection scheme access for TB patients and families. Because we already had the success story previously, but then the policy changed, and I think we can do something again on it. The next thing is regarding the creating an episodic JKN payment system for primary health care under TB strategic health purchasing to incentivize providers to identify and notify TB, implement adherence monitoring and complete treatment. Of course, yeah, I think Ibu Novi is still there online. We will continue our coordination and collaboration with BPJS Kesehatan, but not only NTP, of course, with the related unit like Pusjak PDK, to discuss potential adjustments to the JKN payment system. And here we also will initiate discussion with professional organization and health provider associations. And I think for the fourth main recommendations regarding to the development, implement and sustain a communication and social mobilization plan to partner with communities. We're really willing to strengthen this, and together with the health promotion unit at the Community Health Director General, Ministry of Health, and also Ministry of Communication and Information, local government and related partners, we will continue carrying out wide-scale campaign and health promotion for TB, focus on specific issues of TB case finding, screening, preventive, and support in order to increase, of course, the knowledge, awareness, and behavior change towards TB control, of course. Aiming not only patients and people affected with TB, but also the community leaders, village leaders, and other related sectors, including private. And I think for this, since Indonesia is an archipelagic country with many tribes, ethnic groups, etc., I think we really also need to address some local specific information, which is in accordance, of course, with the local wisdom, and aiming to really get the attention and also action by the local target groups, because sometimes if it's only in Bahasa Indonesia or in Indonesian language or without addressing and also considering the local wisdom, the result can vary. I think it happens in many cases. So we have both the national and also I think in some areas with potential resources and also strong local wisdom, we can combine it with the local specific ways of having the IEC, etc. So I think that's the end of our response that I can deliver. Pak Imran, do you have something to add? Please, Pak. Ada, okay, later maybe. Okay, so once again, on behalf of NTB, once again, I'm really thankful to Dr. Cakaya and all the reviewers, and also to the national team. I mean national, by saying national team is the reviewers, but Indonesians. So we have Pak Pandu, we have Mas Farel, who else? Ibu Dia, many, Dr. Sudianto, everyone. Thank you very much for guiding us, for providing us critically with such comprehensive recommendations, and we are sure that this will help us in strengthening the TB programs. But don't leave us alone, because some recommendations still need your support to be implemented. Thank you very much from me, and I close it with selamat sore. Terima kasih.
Thank you very much, Ibu Tiara, for the encouraging and warm response, which we believe also encourage us to work even harder and better. So now we are already arrived to our destinations. Let me call our pilot for today's flight, Dr. Imran Pambudi, to deliver the closing remarks. So Bapak Imran, the stage is all yours.
Yeah, thank you, Siva, Jonathan, distinguished guests, members of the team, ladies and gentlemen, good afternoon. Assalamualaikum warahmatullahi wabarakatuh. So finally, we in the end of the meeting. And I think many things that already said by Putiara about the response of the recommendations from the teams. Yeah. So I notice here that some points, yeah, that maybe I want to also highlight it. Yeah. So first, I want to thank you for all of the participation, especially from the external team led by Prof. Cakaya and all of the members, and also the national team, yeah, that very rich discussion and rich recommendation also. And I think I want to echoing again, yeah, about the key recommendations from the JEMM 2022, which are first, strengthen TB screening and active case finding by equipping Puskesmas with digital X-ray, with the artificial intelligence, yeah, molecular testing, and in the linkage to identify TB associated comorbid states. Yeah. So for this point, I have review, yeah, maybe Putiara mentioned also that we are, yesterday, Minister talking about how he will equip the Puskesmas with the X-ray. Yeah. And we have around 10,000 Puskesmas, yeah. And I have also read that there is a quite new regulation from Bapeten in 2020. And in this new regulation, I read that we have potential collaboration and potential how we can improve the quality of the services, especially radiology in the Puskesmas. And we are working on that one. And for the laboratory things like molecular testing, I have calculated that if we want to find 969,000, yeah, it means that we need around 5 million tests. And if we test all of these specimens with the gene expert, so we need around 5 million cartridges. And I have calculated that it needs 55 million US dollars. So I think it's not affordable for this one, 55 million US dollars. So it means that we need something testing that more affordable that we have talked, and I think we will have discussed with colleagues from the Bill Gates, yeah, about how we can make this test more affordable, because it's very expensive one. Yeah, we can we cannot maybe if we use 85 million US dollar, so there is no else program that will be funded, right? So we need more affordable one. And also the other things that your recommendations about how we can improve information system. Yeah, and I heard this morning the review from TB HIV. It's also raised this issue, and I also noticed that there is quite discrepancy, yeah, SETB, yeah, TB and HIV. So I think the SITB is quite strong enough if we compare the others. So it means that now in my position, I have to equalize that, not to this one. So I think the information system of HIV should be improved. And that's why I asked Dr. Luki. Where is Dr. Luki? Dr. Luki is still here? Yeah. Yeah. Dr. Luki is former from the TB, and then now I appointed her to be a team in HIV. So it means that how we can collaborate will be much easier for this one. And at least, again, I want to thank with all of the team. And yesterday, for the debriefing with the minister is very wonderful. And the important things is I want to say too that nowadays, maybe after this meeting, minister said that, okay, Pak Imran, now you are not have to report weekly. Not report weekly, but be weekly. I mean, that's the, what we call, he feels confident enough, yeah, to move, yeah, not give an eye every week to me. So it's thank you for this one. Yeah. Thank you for Prof. Cakaya for this one. So yeah, so it means that if I don't have to report weekly, it means that I can manage other things like HIV something. Yeah. So it's more equalized for this one. So I think this is all from my side. Again, thank you very much. I hope you are enjoy in Indonesia, and we can have another meeting maybe after this. Yeah, like Dr. Srinivas already invite us to India, yeah, about Stop TB board meeting, yeah, and my colleagues from Chennai, from NIHRD, from India, yeah, NRT, is also invite us to visit them and discuss about the collaboration about the research. Nah, tahun depan udah nggak grounded ya. And I think I want to end this speech, yeah, with the words that there is always a crack for everything, yeah, and that's how the lights get in. I think we still have something that you already find, and that is how we can improve, and we will have a better for TB program. I think that's all from me. Thank you again. Good afternoon. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much, Dr. Imran, for the very wonderful closing to sum up this activity that we have for the past almost 2 weeks, I believe. So, ladies and gentlemen, we give our deepest thanks once again to our speakers, all our speakers here, who have provided their wonderful insights, and to all, of course, all the participants, both here and also online. We didn't forget you, and for actively contributing to our activity all the past almost 2 weeks now. So I think it was great also, one of the highlights of this activity was the very successful meeting with the minister yesterday, which I think that's kudos to everyone from the review team. We have processed all the information, packaged it very nicely, and sent it to the minister, and the minister received it very well. So a big round of applause to everyone once again, the review team, for all the hard work that they've done. Okay, so, of course, our heartfelt thanks to each and every one of you, once again, distinguished guests, for all your contribution and support during this debriefing meeting of the TB Joint External Monitoring Mission 2022.
So now we, as the master of the ceremony, would like to thank you and for your hard work and for your active contribution until this late afternoon. So once again, thank you and good evening. Wassalamualaikum warahmatullahi wabarakatuh.